not to end up into any kind of morbidity or mortality, because our ultimate goal is to check mortality and morbidity as far as maternal part is concerned, and at the same time infant mortality and morbidity also, because by 2030 we have to reach goal which is given by WHO and government of India, that our maternal mortality rate should be less than 70, that is 67 or so, and infant mortality rate should be less than 12. Of course, there are few states in southern India, they are already having maternal mortality rate near 30 or even below 30. But at the same time, few are the state in northern India and particularly in northern eastern India, they are having maternal mortality near 200. Just before few months, they had maternal mortality more than 200. But in recent survey, it has come down and it has reach to 180 or so. But even then, it is also too high, and it is a matter of concern for us directly being an obstetrician. And if you go join hand, Government of India, NGOs, federation like IMA, FOXY, and our gynecologist friend or whosoever is dealing with obstetric work, particularly in rural India, if we go join hand, if we picked up high risk pregnancy case well in time, if we can refer them and to get them delivered at proper a place where all the facility to deal with the all complications are there, then it is very obvious that we can reach that very goal of maternal mortality and infant mortality, which is given to us to be reached by 2030. So with this, I welcome you all, and without wasting much of your time, welcoming you all again to this Happy Learning Masterclass 254th edition. Thank you very much.
Thank you, sir. And now it is my proud privilege to introduce our chief guest, Dr. Hema Devakar, madam. It is an honor to share this platform with you, ma'am. She is the medical director of Devakar Specialty Hospital, a senior consultant and CEO and chairman at Artist, which is the Asian Research and Training Institute for Skill Transfer. She is the Dean KCOG, the past president of Oxy 2013, the vice chair of FIGO PNCD Committee 2015 till date, elected as chair of Well Women Healthcare at FIGO. She is an advocate for delivering quality healthcare as convener of Manyata. And she's also received the FIGO Women Achiever Award in 2015, the Global Asian Award of 2018, the CME Excellence Award for Artists, and the Next Brand for Artists for her, and CSR Times Award for CSR Impact of Devakar Service Track. Ma'am, we welcome you and we request you to give your address.
Namaskar, everyone. Ellarigu namaskara. Just 1 minute. There is some echo happening.
Ma'am, your voice is echoing. Might be you have joined with two devices.
Yeah, madam, two devices in the China gidare. We can see.
Two devices are there.
Yeah, go on.
Because what we are echoing today is loud and clear that Dr. MC Patel, as leader for the country in the prestigious post of president of Foxy. So maybe the echo was quite in order to say that loud and clear. And I think that 254, in this era of cricket, it is not Sachin Tendulkar, it is not Virat Kohli, it is not Suryavamshi, but it is MC Patel who has really scored a double century, 254th edition of Happy Learning programs. And we are happily all join hands together to learn more and to actually translate those learnings into real life practice. And, South Indians always love idlis and dosas. So when I was thinking why I have to bring this topic in, today's aggregation of the societies of Karnataka, like idli, it's a mini idli. So this is a mini Karnataka, which is all come together here in this Happy Learning program today. half of us are already here on this prestigious program, and the several chain of names that both Monica and MC mentioned, who is participating in this program. This is a great coming together of very distinguished faculty deliberating on very, very unusual topics. And when we think of MC and when we are in crisis, we always think MC Henna. It's like that for us, that the connect that is established with him. So, may on my own behalf, on behalf of everybody from Karnataka and all the delegates in this happy learning experience, also wish him the very best for all times in future. And thank you very, very much for having me as your beloved chief guest. And my connections with MC go many, many decades away, and he very well knows what we mean to each other. So, all the very best for this event, as well as all the directions that one may lead the country in future. Namaste.
Thank you. Thank you, Dr. Emma, for all kind words, and always you are with me in any of my academic activity. And this is fourth episode of Happy Learning Masterclass with Kasoga in this year. So in past also, we
Nice.
had many episodes with Kasoga, and you were always there. Whenever I have invited, you have always said, yes, I am there. So I am
Excellent.
always blessed with your blessings. So thank you for sparing time in spite of your busy schedule. Thank you very much.
Thank you, Namaste. Mm.
Thank you so much, ma'am, for addressing the August gathering and for your
Monica.
blessings to all of us. I now request Dr. Monica Gupta, madam, to introduce our guest of honor for today, Dr. Nagraj sir and Dr. Sajjan sir.
Thank you, MC Patel sir and Dr. Monica for giving me opportunity. It is my proud privilege to introduce such a senior person like Dr. H. Nagaraj sir. He is patron of Kasoga. He has held so many positions in Kasoga, like former president, executive member, charter member. He was a founder president of Shiv Moga Society, and he was has organized Kasoga State Conference in 2005 and 2017, and he's a former president of IMIC Shimoga and the chapter member of Maland Institute of Oncology, chapter member of Shushruta Biomedical Waste Management at Shimoga, and vice president, chapter member. Hello,
Hello.
please mute Dr. Rupa. He's a vice president, doctors, Inclusive Cooperative
It is
Society,
echoing even now. See,
Shimoga.
Yes,
Shiva.
He's interested in high
तेरा
risk
कमरा
healthcare issues.
इको हो रहा है
हाँ,
रूपा म्यूट ಮಾಡ್ಕೊಳ್ಳಿ please.
And I request Nagaraj sir to give his words of blessings
Hello,
for our
everyone. Thank
webinar
you.
and for MC Patel sir.
Thank you for the opportunity. Namaskar, beloved Dr. MC Patel sir, Program Director, former Vice President Foxy, and a legal expert for
Hello.
Foxy. Convener Dr. Monica Umbar Dand, Chairperson Direct, Public Awareness Committee, Foxy, Coordinator Dr. Deepika, Shanta Shantavide, Dr. Nivedita Datta, Mega Kamala, our own member, Dr. Rekha Rajendra Kumar, EC member Kasoga, and Chairperson Medical Disorder of Pregnancy. Chief Guest Dr. Hema Devakar, Past President Foxy and Kasoga, CEO Artist, and future President of FIGO, my dear friend Dr. Basara Sajjan, former President of Kasoga and treasurer for innumerable number of years, esteemed faculty, chairpersons of the sessions. I should admire Dr. MC Patel for his untired efforts in organizing happy learning master classes. Today is the 254th. I feel that he will break the record of Tendulkar. He has involved seven societies of the Kasoga with luminaries in the field of OBJ, and is involving Baso Kalyana, Chikmagalur, Hassan, Haveri, Manipal, Mysore, and my own Shivamoga Society. He has devoted part of his busy schedule in sharing the knowledge and update the members in Foxy and Kasoga. I am thankful for his entire team for their untiring efforts. I am happy to be part of this webinar and have a learning experience. I wish him all success in these upcoming elections of Foxy. He is a man of action. We wish you all happy learning. Thank you once again.
Thank
Thank
you,
you.
sir. Nagraj sir, you are always with us, and whenever we have call, you have always said, yes, I will be there. Thank you for sparing time for us.
Thank you, sir. With the blessings of senior persons who is a patron of Kasoga Society, we wish we will get full support from your society for MC Patel, sir. Our next guest of honor is Basavraj Sajjan, sir. He is a former National Vice Chairman, Medical Wing, NBSS PFI, Ministry of Consumer Affairs, Government of India, former Vice Chairman of Kasog and Kasoga, past President of Kasoga, former Senior Specialist in OBGY in Hubli and Kopal, former South Zone Coordinator for HIV/AIDS Foxy Program, former DHO at Haveri, Executive Member of AIDS Society of India, Karnataka State Award for Family Planning Program, Kalyan Karnataka Award for serving in Hyderabad, Karnataka, past President for Rotary Club at Kalghati, and Community Services Award for Rotary District 3170. And he has got a vast experience of 45 years. Over to you, sir, for your blessings.
Thank you very much, sir. MC Patel, sir, for inviting me for as a guest of honor to this 254 webinar, sir. And I wish a grand success, and it should enter in the Guinness record that you are continuously all over India are giving a very good education and a medico-legal expert. In Karnataka, all Kosovo members on behalf of, there are 3,000 members. We promise, I request on behalf of Kosovo as a past president to support and vote for your future election. And this excellent webinar you are conducting and you are giving a lot of informations, and you have attended all our Kasoga conferences, and as a medical expert you have advised all our doctors in Karnataka. There are less medical legal cases because of your advice, your support, your guidance, everything, and we had very less cases because of you, sir. And we are having our Karnataka, many societies are participating in this program. Excellent topics, excellent speakers, and Hema Divakar Madam, we wish her as a FIGO president, and you are also become a Foxy president. On behalf of Kasoga, we support. Thank you very much, sir, for inviting. Grand success for your future career. Thank you very much, sir. Thank you. Namaste.
Thank you.
Namaste.
Thank you, sir. We are overwhelmed by your words. You will support MC Patel, sir. Thank you very much.
Thank you.
Sir, now with your permission, should we start with the academy program
yes.
after the closer
Yes.
of
Before that, thank you.
session?
Thank you.
And with
Thank you, Basavraj sir, for sparing your
Yes.
time.
Yes.
You are always with me. Whenever I have called, you have simply said, yes, I am there. So thank you for sparing time for this webinar, and thank you for all your wishes and support for my future endeavor in Foxy. Thank you, sir.
Thank you. Thank you very much, sir.
Yes.
Thank you all the esteemed guests for joining us today for the inauguration ceremony. And I would now request Dr. Deepika Lugane, madam, to please start for the first session.
So, good evening to all our distinguished guests and the delegates who have joined in from the other side. And I'm Dr. Deepika Lugane, and I, at the outset, thank Dr. MC Patel, sir, Dr. Monica Omardand, and Dr. Monica Gupta for giving me this opportunity. And as sir has already said, this is the 254th edition of the Happy Learning Masterclass, and we begin with our first scientific session. The topic for this session is how to prevent isthmocele during LSCS. and it is my privilege to introduce our esteemed chairpersons for this first session. Our first chairperson is Dr. Sureka Handral ma'am. Ma'am is the past president of Haveri Obs and Gynae Society 2022 to 24 and is a senior consultant at Handral Sukhyada Hospital at Haveri. A dedicated obstetrician and gynecologist, ma'am is committed to promoting women's health and well-being through compassionate, patient-centric, and evidence-based care across every stage of women's life. Ma'am, a very warm welcome to you. Our next chairperson is Dr. Jayashri S. Ma'am is a consultant in reproductive medicine at Spandana Fertility and Women's Wellness Center at Mysuru. Ma'am served as the president of the Mysore Obs and Gynae Society 2023 to 24, having earlier served as its secretary also. Ma'am's area of special interest include reproductive medicine and gynae endoscopy, and ma'am has authored numerous publications in national and international journals. Ma'am, we are delighted to welcome you as our chairperson. Our next chairperson is Dr. Jyoti Krishna Gowda.
ಅದೇ ಮೊನ್ನೆ ಡಾಕ್ಯುಮೆಂಟ್ ಕೇಳಿದ್ರು ಅದು ಮುಂಚೆನೆ ಕಳಿಸಿದೀನಿ ನಾನು ಅವತ್ತು ನೀನ್ ರೆಂಗನಹಳ್ಳಿಯಿಂದ ತಗೊಂಡೋದಲ್ಲ ಅದರಲ್ಲೇ ಇದೆ ನೋಡೋದು ಡಾಕ್ಯುಮೆಂಟ್ ನೋಡ್ರಿ.
Madam, I think somebody started sharing the screen. Can we have the tech team just look through this?
Yeah, resolved, man.
Okay, so anyways, I will introduce our third chairperson for the session, Dr. Jyoti Krishna Gowda ma'am. Dr. Jyoti Krishna is a senior consultant obstetrician and gynecologist at Secure Hospital at Chikmagaluru with nearly 5 decades of distinguished experience in clinical practice, teaching and women's healthcare. Ma'am is the co-founder of Joindale Nursing Home, the first nursing home established in Chikmagaluru, and has served as assistant professor and surgeon at MR Medical College, Gulbarga. Ma'am has been the past president of Chikmagaluru OBGYN Society and has mentored generations of doctors and continues to inspire through her lifelong commitment to the profession. Ma'am, we are honored to have you as our chairperson. Can I request one of our chairpersons to please introduce our speaker, who's our speaker, Dr. Shanta Durge ma'am.
Rupa ma'am, can you please stop sharing the screen so that the technical team can share the CVs? Hello?
Can the technical team stop it from their side? No?
No. Now, is the technical screen seen now, right now, ma'am?
No.
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 Just a second. Let me look at this.
No, because I can see Rupa madam's screen there.
Yes, that's right.
She will have to stop sharing.
I just called madam. I think she'll do it.
Yes, ma'am.
Okay, so now we are back onto the home screen.
Yeah, so the technical team, can you please display Dr. Shanta Durge madam's CV for the chairpersons?
Yes. So can we request our chairpersons to, is Dr. Jyoti ma'am there?
Yes, I can see her.
Dr. Jyoti ma'am, can we request you to introduce Dr. Shanta Durge ma'am?
Okay, I'll go ahead otherwise.
Yes, ma'am, please.
Yeah, Dr. San. What's screen?
Yes, ma'am.
Ma'am, you need to unmute.
Yeah. Good evening, madam. Yeah, Dr. Shanta Durge, madam. She is a clinical director and chief consultant at Durge Clinic and Fertility Center, Basava Kalyana. Nominated member to a Karnataka State Supervisory Board, PCPNT Cell 2023 to 25, and recipient of a Corion Award and Distinguished Community Service Award at Foxy, and Godfrey Phillips Bravery Award, Odisha, and many state awards. Faculty at many AICOGs and state conferences. Kasoga and Karnataka Chairperson for Public Awareness Committee 23-25. All India Radio and TV Talk. Wrote 2 novels and 40 plus write-ups on female feticide. Founder for Save the Girl Child and to protect girl rights since 29 years. She's a founder of Basava Kalyana OBG Society. Thank you, madam. Over to you.
Shanta ma'am, please unmute yourself.
Yeah. Thank you. Can I share the screen?
Yes, ma'am. Can the tech team stop sharing the CV? Yeah. Yes, ma'am. We can see your screen. Please make it full screen, ma'am.
Can you see the screen?
Yes, ma'am. Now it's fine. Perfect.
Thank you. So today, as there is a rise in correct cesarean sections, we are seeing so many consequences of cesarean section scar. So this is very important to learn the correct suturing techniques for cesarean section, and today's topic is the same, that is correct suturing techniques for cesarean section. And cesarean scar, we see always some long-term consequences. So the technique and the suture material used are crucial for the uterine scar healing. Strong evidence regarding optimal technique is not yet established. Then optimum healing of the scar after cesarean sections is of paramount importance for future reproductive outcome. The defect which appears on the in the cesarean scar after in the previous cesarean cases, that is the defect in the cesarean section scar, that is also called as isthmocele or uterine nick. And this has to how we will diagnose this deficiency in the cesarean section scar. Once we diagnose it, then how to prevent it, that is more important. So for diagnosing the isthmocele, we have to go for the transvaginal ultrasound. So this is the picture of isthmocele which appears on transvaginal sonography. You can see the defect in the uterine scar, that black triangular area, defective area in the myometrium, and starting from the endometrial cavity, the base which is pointing towards the uterine cavity and the apex towards the upper side. So this is defined as an indentation representing myometrial discontinuity. And with this, another picture shows the hysteroscopic picture, how we diagnose inside the uterus. The importance of this isthmocele is there are many severe consequences, and so prevention is much needed. Today we are dealing with the same. According to a systematic review, the percentage of this nick or isthmocele is 56% to 84% when examined by the transvaginal sonography with contrast. Defective residual myometrial thickness is linked to adverse outcomes like postmenstrual spotting, uterine dehiscence or rupture, placental acarita spectrum, infertility, and lower implantation rates, caesarean scar ectopic, and so on. This is all because of the poor healing of uterine incision. To perform the caesarean section in an optimum way, the choice of suture material is very important. Of course, this depends on the mainly surgeon's personal preference. Then, vicryl suture is commonly used as number 0 or number 1, and sutures which are coated with antimicrobial compounds may decrease the rates of surgical site infection. Barb sutures are much better, but they are costly. We all know the disadvantage of the catgut. Directly we will go to the polygalactin 90, that is vicryl, which we use commonly in our surgeries. And this is absorbable, braided multifilament, coated synthetic suture available with an antibiotic impregnation with a triclosan and residual tensile strength of a polyglactin 9-10 suture is greater and is absorbed more rapidly. Absorption starts at 40 days and completes by day 70 with no remains by day 90, that is 3 months. It retains 75% of its tensile strength at 2 weeks and 50% at 3 weeks. Less tissue reactions and promote faster wound healing with good strength. Then the next point is uterine closure, exteriorization versus in situ closure. Many of people, they opt for the exteriorization. Then we'll see the advantages of in situ and exteriorization in a systemic review and meta-analysis. Clear evidence of the best method of uterine closure is not yet established. In situ closing of uterine incision is preferred, and then FIGO 2023 recommends recommends FIGO 2023 recommends exteriorizing in certain situations. And the advantages of these are good exposure to facilitate closure of the hysterotomy, number of sutures are less, operating time shorter, effective and easy uterine massage, and easy adnexal examination. Disadvantages are intraoperative nausea and vomiting because of the intraperitoneal manipulation, and risk of intra-abdominal pelvic adhesions due to possible abrasion of the uterus and higher post-operative pain requiring analgesia for more hours. According to NICE 2024 guidelines, exteriorization of the uterus is not recommended. SOAP. This is what is SOAP? This is Society of Obstetric Anesthesia and Perinatology, and RCOG and Cochrane review limits the exteriorization or recommends to avoid it. And even the abdominal saline irrigation is also not to use routinely. Then whether the next question is whether we have to include endometrium, include or exclude endometrium. If we include endometrium, there is a chances of neck formation, ischemosal, and exclusion gives rise to reduced neck formation on saline infusion sonogram. This is evidence-based, and minimum abnormal implantation of the placenta, that is the accreta, placenta accreta. Decidual, according to a study, a book written by Ramalingappa in 2021 on optimizing techniques and suture materials for cesarean section, decidual inclusion results in defective uterine healing in 78% of cases, and so decidual exclusion resulted in better healing. Then the question comes whether it is the single or double layer closure. Single layer closure, advantages we all know, it saves time, good with any permanent contraception like tubal ligation. A continuous unlock technique may be the best by FIGO 2023. Uterine rupture in subsequent pregnancies is a theoretical concern, and single layer closure does not increase the risk of postoperative bleeding or uterine rupture in subsequent pregnancy. This is from NICE Guidelines 2021. What are the disadvantages of the single layer closure? According to a cohort study in 2010, the disadvantage is 7-fold increased risk of bladder adhesions in single layer cases. Then in double layer, even triple layer closure. NICE Guidelines 2024 says use of single layer or double layer, it depends upon the clinical circumstances. RCOG and ERAS. ERAS is an enhanced recovery after surgery. In 2019 recommend, RCOG and ERAS recommend double layer closure of the hysterotomy unless the patient desires no future fertility without further guidance on the type of closure. According to systematic review of meta-analysis 19 RCTs 2021, double layer uterine closure technique was associated with more residual myometrial thickness and lesser dysmenorrhea compared with single layer closure technique. Then the question comes locked versus unlocked closure. Available data are limited. FIGO 2023 says available data are limited by heterogeneity. Then about the locked sutures, thinner myometrial thickness, and bell-shaped uterine wall defects, higher occurrence of markers of scar weaknesses, dehiscence, or rupture, then locked single layer closure is associated with an increase of uterine rupture compared to double layer closure. So, double layer uterine closure with a first unlocked layer, excluding decidua, compared with locked single layer closure, including decidua, is associated with a greater RMT and better healing. So, double layer uterine closure is recommended. According to study 2021, Journal of Investigative Surgery, a randomized controlled study says this continuous unlocked double layer technique is beneficial in prevention of stomacal formation and ensuring sufficient RMT. Now, in case of classical incision, how to close the incision wound site? Till today, there are no trials, and it says placing figure of 8 sutures in the lower one-third of the incision, but not tying them at the same time, keeping the sutures on the surgical clamp and then going upwards for the one-third of the upper side. Suture the one-third of the upper side first, and then come to these sutures which you have kept on the surgical clamps to tie it in sequence. And then the second layer of myometrial closure and the third layer of myometrial closure. So classical incision, closure of a classical incision is advocated in 3 layers. This is according to the FIGO 2023 good practice recommendation for correct surgical techniques. Then the question comes of intraperitoneal irrigation. Intraperitoneal irrigation should be avoided due to increased intraoperative nausea and vomiting without other guidelines. This is according to Society of Obstetric Anesthesia and Perinatology in 2019. Then comes the peritoneal closure, question of peritoneal closure. RCOG recommends neither the visceral nor the parietal peritoneum closure. Even Coronis RCT trial, the famous Coronis RCT trial in 2013 says visceral and parietal peritoneum closure not advised. About the rectus muscle, routine reapproximation of rectus muscle at primary cesarean section is not indicated because it increases postoperative pain and analgesic use, and advantages are less adhesion formation, and each case has to be individualized before reapproximation. Of course, it depends upon the clinical situations. Then even once you have decided to close the rectus sheath, the study Ramalingappa 2021 states that the continuous sutures without any locking is beneficial. It avoids high tensions on suture and does not compress the wound edges. This prevents devascularization of the sheath and formation of a good quality collagen, that is type 1. And it gives speed to the surgery since knots need not be tied at 2 or 3 points. You can take interrupted and figure of it to strengthen the rectus sheath closure. In case of mass closure of abdominal incision in vertical incision cases, this is used, mass closure of abdominal incision, according to NICE guidelines 2004, updated in 2024, says use mask closure with slowly absorbable continuous sutures, as this results in fewer incisional hernias and less dehiscence than layered closure. Then closure of subcutaneous tissue is not routinely advocated in overweight and obese patients. If the subcutaneous fat is more than 2 or equal to 2 centimeter thick, then this is indicated. And according to FIGO 2023, this is indicated in more than 2 centimeter subcutaneous fat, and use of superficial wound drains are not routinely advised. Now the tissue adhesives. This is the new theory. Tissue adhesives. We we routinely suture the surgical wound in subcuticular for the younger patients. But then this new technique, according to peer-reviewed chapter by Ramlingappa 2021, this glue or synthetic subcuticular, this glue, which is the adhesive, the advantages are lower infection rate, less operating room time, good cosmetic results, lower cost, ease of use with immediate wound healing, faster return to work, elimination of needle stick injuries, and eliminating the need for post-operative suture removal. But the disadvantage is of cost factor. And I think I have cleared almost all the points how to optimize the cesarean section scar. Thank you, and thank you all.
Thank you, Shanta ma'am. I think this is a very, very pertinent topic because scar isthmocele and subsequent placenta accreta is probably the nightmare of all obstetricians here. So thank you very much for giving us a very concise but a very lucid presentation about how to do the perfect cesarean section. Thank you once again, ma'am. And I would request the chairpersons to please give their inputs for the same. Do we have the chairpersons with us for the session?
Okay. Thank you. Thank you, Dr. Shanta Durge ma'am, for that lucid presentation on how to prevent isthmocele. And I think it is very important that we follow proper techniques during cesarean section so as to avoid complications in future. Thank you very much for enlightening us so well on the technique of cesarean section.
Thank you. Thank you, ma'am.
Thank you once again, ma'am. And moving on to the second session on yet another very pertinent topic about preterm pre-labor rupture of membranes and intra-amniotic fibrin to seal the pre-viable amniotic fluid leaks. And to chair this session, we have again very experienced obstetricians. We have with us Dr. Basavraj Kohli, sir. He has. Am I audible? Okay, a very senior obstetrician and gynecologist from Kohli Hospital, Maternal and Child Health Care and Research Center, Jayadin Nagar, Karnataka, Haveri, Karnataka. His objective and goals are maternal and perinatal health care, reduction of maternal and perinatal morbidity and mortality, women's health, nation wealth. I loved his line about pilgrims of my service. Assistant Professor, JNMC, Belgium, 2005 to 2009. Consultant at Sai Baba Charitable Hospital, Shirdi in 2009. Medical Officer in Sikh Neonatal Care Unit at District Hospital, Haveri. And consultant at Kohli Hospital, Haveri from 2010 till that date. He is at present the President IMA Haveri from 2026 onwards, and he was the Vice President of IMA Haveri till 2025. He is the Founder Secretary of Haveri Obs and Gynae Society, which was founded in 2022 to 2024, and a member of HDOGS Obs and Gynae Society. Before that, life member of IMA Haveri, Joint Secretary Belgavi Obs and Gynae Society, and he's been a member of Belgavi Obs and Gynae Society from 2005 to 2009. Contributor for training of medical officers on essential obstetric care and newborn care. He's got 50 years of service, co-founded the first nursing home in Chikmagaluru, mentor to generations of doctors, and he's a trustee of Asha Kirana Charitable Trust for the Blind, associated with Ashraya Foundation. Welcome to this session, sir, and a very commendable and a very illustrious career which you have had. The next chairperson for this session is Dr. Bhagya Karthik, ma'am. And what I loved about her CV was the her frame of the CV, the last pallo of the sari, which like the pallo of the sari. It's such an exotic CV which she has. Her qualifications: an MD, FRM, and she's a medical director of Ashraya Fertility and IVF Chikmagalur. She is a reproductive medicine, gynae, endoscopic surgery, sonology, high-risk pregnancies are her area of interest. The past secretary of Chikmagalur Society of Obs and Gynae, and has delivered many firsts in IVF in Chikmagalur and speaker at school health sessions for adolescent and teenage girls. Welcome, respected chairpersons, and I would request any of the chairpersons here to please introduce the speaker for today.
Hi, ma'am. Shall I do, Dr. Soumya, ma'am?
Please go ahead, ma'am.
Yeah.
Please go ahead.
Hi, Soumya, ma'am. Good evening.
Very good
Dr.
evening.
I know Dr. Soumya Dinesh from a long time. So Dr. Soumya Dinesh is the founder and director of Santasa Fertility and IVF Institute, Mysore and Hassan, and she runs the SSM Multi-Speciality Hospital Private Limited at Hassan. She's won a lot of awards, Accelerating Innovation Award, IASRM 2024, Innovators and Innovation Award, IASRM 2023, Jana Mechida Vaidya 2024, Amma Award 2023, Best Woman and Entrepreneur by Times of India 2020, Fetal Medicine, I think FM Super Sadaki 2018. So the position she holds a member of Karnataka State Government ART and Surrogacy Board 2024, Santasa Foundation. She's the author and translator, has contributed to a lot of textbooks and patient education. She's a joint treasurer of KISAR to 2018 to 2020 and 2026. She has a lot of publication documenting the world's first usage of intraamniotic PRF in preventable PROM. I actually listened to this talk in the last Kasoga, and it was very informative. I'm sure all of us can include this procedure for our cases, especially in IVF where we have high risk pregnancies. I'm sure her talk will be very beneficial for everybody. So I hand it over to Soumya, ma'am.
Thank you so much, Dr. Bhagya. Very nice seeing you here.
Yeah,
And
nice.
my sincere thanks to Dr. MC Patel sir and Dr. Rekha Rajendra Kumar for this kind invitation. Pranams to our ever-inspiring Dr. Hema Divakar madam and my mentors, seniors in Kasoga, Dr. Basuraj Sajjan and Nagraj sir. And a warm hello to all of you. Today, what I would be talking, let me just share my slide. 1 second. Share. Okay. It is big. You can see, right? Can you see? I'm sorry. One second.
Yes, I can see.
Yes, ma'am. Only make it full screen.
Yeah, full screen. I'm trying to make it full screen. Where is it? It is here. Yeah. Is this fine?
No, it's still not full screen. There's a just at the bottom you might find the full screen.
Press on the full screen button.
Otherwise, no, it's not coming up. Then above you might see something like play full screen or something.
Yeah, 1 second.
Soumya, come down to the cup here near the volume.
Is it there? Can you hear?
No, not as yet. But anyway, please go ahead. Let's see if the slides are
Yeah,
visible.
ma'am, below there's the
Ma'am,
option written notes
slide,
and yeah, right side. Yeah, you can
yeah,
access from here. Yes.
Yeah,
slideshow. If
yes,
you put
yes.
slideshow, it will come as full screen.
Yes, click on that. Yeah, click. I have done it earlier, but this time when I'm doing it's not kind of, taking it. Let me just see. Let me just see.
Ma'am, you click on resume slideshow. Yeah, you got that resume slideshow.
Yeah.
It was just flashed right now.
It is not coming, no?
No issues. I think you can continue.
Yeah, I think that is okay. Let me just enlarge the screen, but still it would be better in case if I do this way. Last try. Okay. So anyway, what I would be talking is a very interesting topic, problem which has haunted obstetricians worldwide. And whatever I'm going to talk, it looks quite, sometimes unbelievable, but you need to kind of place the trust in us that we have done an amazing study. And I'm going to present the details of the same. So I bring warm greetings from my institute, Santasa Fertility and SSM Hospitals. Without much delay, this is the outline of my talk. Here I would be talking what is pre-viable PROM, what are the causes, current management, why did we do this innovation, what did we do and what did we do differently, and what is that protocol that we are using, and the details about our multicentric study, results of the study, and couple of take-home messages. I'm sorry, but I think all this is coming right when I'm, all this, everything is it moving? No? No. I'm sorry, somebody, can you just communicate with me? Is my slide visible?
It's visible, ma'am.
Yes, ma'am, it's visible.
Yeah.
From the tech team, it's
Go
visible.
ahead.
Yeah, it's
Okay.
visible.
So whenever there is rupture of fetal membranes before the onset of labor, it is termed PROM, as all of us know. When it happens before 24 weeks, it is pre-viable because the fetal outcome is going to be very, very guarded. It's a serious complication of pregnancy with high rates of morbidity and mortality for both, for babies in particular, and mothers have a lot of morbidity because of infection and pre-viable leak, which can pose sometimes the risk of mortality as well if she gets into chorioamnionitis and sepsis. It's important because if we push that gestation from 22 weeks, where the survival is almost zero and the survival without morbidities is very meager, to just another 5 weeks, survival becomes close to 90% and survival without morbidities becomes 64%. 2/3 of those babies will survive. And we know that extreme prematurity has a lot of burden for babies. All of us, we understand mother. And one point that I want to highlight would be the enormous economic stress the couple undergo, along with emotional burden. Coming to types, there are two major types depending on the etiology. One is spontaneous and another is iatrogenic. Iatrogenic is caused by procedures, mostly amniocentesis. Spontaneous is caused mostly by infection, cervical incompetence, and leading through pregnancy. Uterine overdistension in cases of twins can be one of the main causes. History of previous PROM can be a risk factor, as well as whenever the woman undergoes cervical insert, we need to keep our mind open for the possibility of leak. Though we can't say cervical insertlage will cause the leak, it might precipitate the leak which could have happened otherwise. The current standard of care is very much limited because we know, all of us, we know the obstetrician will be very hopeful of the leaks stopping on its own, which never happens usually. Or like the couple would understand and they would opt for termination because prognosis is very bad for the baby. However, clinicians and researchers worldwide, they have tried a couple of aggressive or interventional therapies like amnio infusion. Amnio patch is the most catchy word, most of you would remember. Then cervical plugging with fibrin glue, and a lot of interventions they have done, but none of them has been proved to be of any value to routinely recommend in our clinical practice. So the most well-known is amnio patch, which uses PRP, cryoprecipitate, and normal saline with the total volume of 350 ml. I want to highlight the fact here, the total volume that is used in pre-viable gestations. That means if they are less than 24 weeks, the uterine size would be small. And in case if you are going to push so much of fluid volume, it may not hold. The defect size, the whole size might increase. So that is why it has not given any good results. And there is also concern that a couple of women developed amniotic bands inside, and there are reports that many babies lost their arms or legs because of the bands. Most importantly, it doesn't restore amniotic fluid volume, and there is a big body of evidence which shows after undergoing amnio patch, the neonatal outcomes didn't improve. That is why, since there are currently no curative options, that is why there is need for further research and discovery of whatever protocols that may be beneficial to our women. So how did we get into this study? Basically, I'm a fertility specialist. However, I happened to care for a woman who had conceived and she had lost her previous pregnancy. So the first pregnancy was also conceived with fertility treatment with us, but she lost that pregnancy at 18 weeks because of pre-viable leak. Then again, with a lot of additional counseling and treatment with again IUI, she conceived again, and this time we were very skeptical that she might end up with some complications like leak. So we also, since last pregnancy was a mid-trimester miscarriage, we also put a cervical stitch. However, after a couple of days, she developed leak again. We didn't know what to do because all that we could do, we had already done. And I was like, I thought of doing something what researchers in some other part of the world would be doing. And I browsed the literature, tried to find some procedure which I can do for her. But surprisingly, there was nothing reassuring. So we devised a protocol which was very, very simple. I will tell you what we did. We did intraamniotic injection of platelet-rich fibrin and platelet plasma cellular fraction. I will tell you what are they. The total injection volume that we injected was only 13 ml, and there was dramatic cessation of leak. Initially, we couldn't believe it ourselves. Then we thought, okay, maybe it is temporary effect and she would leak again, but she didn't leak, and she continued to 35 weeks and delivered a very healthy baby. So this particular case report has been published in 2024 in Reproductive Female Child Health, which has an impact factor of 5.8. It's an open access journal. So this particular case report gave us 3 credits. It was the first ever use of platelet-rich fibrin in a case of PROM. And also it is the earliest gestational age at which a case of spontaneous PROM had been successfully dealt by an active management. Till then, no one had tried to salvage a pregnancy at that early stage. It also documented longest period of continuation of pregnancy for a total 149 days, that is almost equal to 21 weeks. So what did we do differently? We documented the distinct advantage of liquid PRF, which is a simple one-spin protocol. We used a very small volume. We believed in the philosophy that fibrin will seal while platelets heal. I would like to bring your notice to the common understanding of what is platelet-rich fibrin. We all understand that this fibrin glue. This is the one which is normally which comes to your mind whenever we think of PRF. But this is not the form of PRF that we can use inside the inside the amniotic cavity, because it has to be fluid like this. It has to be injectable through a small bore. So we use liquid preparation that is called IPRF. The preparation of, but all over the world, no one has injected liquid PRF into the amniotic cavity, and no one knows how much to inject, where to inject, and all those issues. We try to find some answer. So we prepared using mouse embryo assay tested polystyrene tubes. For PRF, we used 800 RPM for 8 minutes. For PCF, initially when I prepared this, the study was going on and we used 1000 RPM, but later we made it 1800 RPM for 10 minutes. We kept blood drawing to centrifuge to less than 2 minutes because PRF is well known to clot. So once it clots, we can't inject through the small bore. And also preparation to injection, we kept less than 15 minutes. Temperature, we kept less than 26 degrees. So this is the Santasa IFP procedure, the intraamniotic fibrin and platelet injection procedure. As a short form, we call it as IFP for now. I will play the video. Please let me know if it is playing.
Yes, ma'am, it was playing. Yeah.
Yeah. So this is very simple. After centrifuge, we collect all the supernatant. It comes like this. We aspirate the entire PRF and PCF. We mix together. Then under ultrasound guidance, we inject inside the amniotic cavity. As all of us know, this procedure doesn't require anesthesia since it's a single prick procedure. And women, recently when we did this procedure on a woman, she said, how did it feel? Then she said, it was just like an ant biting. So it was very simple. And we demonstrate a fetal heart, of course. Yeah. As a next step, after we were very thrilled what happened to that woman, how successfully it healed, but we didn't want to believe that it works in other women. We wanted to prove it to ourselves, whether if this particular protocol really works. So we started multicentric case series with like-minded people. When I presented this case report, they said, okay, I'll also be part of this study. So in 5 centers we started. We over time we accumulated, we did, as on today we have done up to 19 patients, but what I'm presenting in these slides would be the 12 cases which we are ready to publish. The first 12 cases, out of them 8 successfully sealed, demonstrating around 67% of efficacy. And out of them, 11 healthy babies have been born because there were 3 sets of DCDA twins. I think Dr. Sonia is also here. One of the twins belong to her. This is the study protocol. Like you can take a screenshot of this because I don't want to take a lot of time. The most important aspect that I want to highlight would be we used local cervico-vaginal asepsis. That means we actively cleaned the vagina and cervix with powdered iodine, and we also kept powdered iodine pessaries. So that there would be no, the risk of chorioamnionitis would be very less, because we believe that however high the strength of antibiotics that you use, it can only be in the blood and it can't go and sterilize the vagina. So basically the woman would get into chorioamnionitis because of ascending infection, and if we are leaving that cavity, the dead space, vaginal space, without much asepsis, then we might be putting her at risk. So this is a very new concept that none of the previous investigators investigators tried to look at the local aseptic precautions. So we have added that in our study, and impressively, none of them developed chorioamnionitis, and also all the inflammatory markers like CRP and ESR, WBC count, they kept on decreasing over time. There was not even a single case which increased in our study. Also, we used atosiban to keep the uterus, relaxed, so that the uterine activity itself can increase the membrane defect size. So we wanted until the fibrin threads went inside, made a plug, and sealed the area. And they also tried to accumulate the platelets. When the situation is so crucial at that time, if uterus starts contracting, then the very purpose of mechanically sealing would be lost. So we used atosiban for 24 hours. This is the summary of our cases. You can see, I will just highlight, gestational age at the onset of leak was 17 weeks, 6 days. And when we did this procedure, it is almost like 4 or 5 days within that time. Not even 4 or 5 days, within 2 days time, we have done the procedure. You can see this is like 8 patients leak stopped, and this is the group where it didn't stop. You can also you can see that the AFI at the day of procedure, where the average was 5.8, which increased to 8.7. In the other group, where they didn't respond, the AFI was 4, and later they continued to leak, and it became close to anhydramnios. One powerful indicator of success was the volume of PRF that we used. In those women who stopped, we used close to 12 cc, whereas in those who didn't stop, the volume was less. Why it was less? Was because in the initial phase, we didn't know what is the optimal RPM that we have to use. And 4 out of 4, I think 3 of them, the PRF clotted. So we didn't get much PRF to inject. So that could be the reason why they didn't respond. Then gestational age at delivery is very impressive. Look at all these women who leaked from 17 weeks, they went up to 36 weeks near term. 2 of them crossed 38 weeks. Total prolongation of pregnancy in weeks was 18 weeks compared to a couple of days in those who didn't respond. Birth weight varies 400 grams and varies 2.7 kilos. So such a massive difference. The ICU stay for the babies, on average, it came up to 1.8 days. That's it. So then we also wanted to see, when we are treating a woman of 22 weeks, we can't say no to a woman who comes at 26 weeks. So we did for many of them. You can see there are 6 cases presented here. Out of them, 4 have responded. You can look at the gestational age, 24 weeks, 26 weeks, 3 days, 26 weeks, 5 days, almost 27 weeks, DCDA twin. Like babies were 800 and 900 grams when the woman came with active leak. You can see active leak, how it is like, on the medial surface of the thigh, there would be a streak of water going down. So like that, she was leaking. She delivered this portion of the screen. I'm not able to see because, it's not going into, what is that, slideshow. More than 2 kilo babies she delivered. This is very impressive. And another one, we tried at 28 weeks, but the leak recurred after a couple of days, so she got terminated. So even after 24 weeks, it is working. We are not sure of using it for 28, 29 weeks and all, but we are starting another wing of the study where we are planning to do it up to 32 weeks, because after 32 weeks, I don't think so it really matters. So we are planning to do it up to 32 to 34 weeks. So coming to inferences, leakage starting before 20 weeks had the highest chance of stopping, and higher the gestational age, the chances of stopping were lower. Chronic cervicitis may be one of the indicators to indicate that this patient may not respond. Cervical encerclage had a favorable effect. Those women who had cervical stitch in situ and then they leaked, they had all of them stopped. In this group, there were 6 women, so all of them stopped after if they had cervical stitch in situ. What I would be thinking is maybe the cervical stitch in situ would not allow a lot of fluid to escape, and it gives some time for us to act. And also, 2 of them were in our center only who underwent cervical stitch, and then they leaked. So we could do like within matter of hours, couple of hours. So that also could have influenced. So here is a video which I play just to show you the impression, like how it might be helping. So this is how usually the lower portion of the sac that tear develops. So we draw the blood, 30 to 60 cc depending on the gestational age. We process, we spin, and it's a single spin procedure which can be done in any remote places. We take all the supernatant and inject. The volume that we have injected varied from 14 cc to 25 cc. Fibrin is a linear molecule. It will be like threads. So other threads will go make a mesh in which platelets will get embedded, and they will release healing factors, which would cause amniocyte migration, conversion to fibroblast, mesenchymal cells. They will bridge the gap, and then again they will get converted into epithelial cells. That is the way how this transformation happens inside. I don't want to take much time on why we use platelets. Yeah, we used fibrin because it has 3D structure. It provides a perfect biological scaffold. It also gives mechanical sealing of the pore in the amnion. This transformation of epithelial cells into fibroblasts and fibroblasts becoming again epithelial cells, it's called epithelial mesenchymal transition and mesenchymal epithelial transition, which has been widely studied by mostly by Japanese group of scientists. So what is the potential of this therapy? We know that worldwide there are 140 million babies. And in case if you consider only pre-viable PROM, almost 7 lakh babies would be lost every year. If you consider up to 27, 28 weeks, then it can be that this figure will be enormous. Like maybe it goes to a couple of millions. So that many lives can be positively affected, and they could be saved. In case if we all together make bigger studies and refine this protocol, make it more efficient, or figure out what is the dose per gestational age, all those factors, if we can make it solid and we get good information on that, we can save that many babies. Putting in other words, all of us have seen the heartbreak the couple undergo when they have such tiny babies. That can be converted into a very peaceful and pleasant motherhood and childhood as well. Yeah, these are the additional references. This is the conclusion. Screening and treating cervicovaginal infections during pregnancy has largely been understudied and requires a lot of further exploration. Combining fibrin and platelets is a simple, low-cost and effective treatment for PROM. This is the initial data that we are producing before you in this small pilot case series. Further research is needed to fine-tune this procedure. I thank one and all for your kind attention, and for Dr. MC Patel for giving this platform to share my thoughts and our original research with you all. Thank you so much.
Thank you, Dr. Soumya. Wonderful. I mean, I think the chairpersons, before the chairperson speak, what I would like to state is that India, being the leading country for preterm births, with this procedure which you have, which you're trying out, fantastic. I mean, I think we can have a drastic reduction in the incidence of preterm births with this. So over to the chairpersons. Dr. Soumya, I've already put in the chat box. If you could post this publication in the WhatsApp group, that would be excellent. So that,
I will do that.
Others can also get a very good idea of the same. And now over to the chairpersons to give their inputs onto this wonderful innovation. Dr.
Thank you so
Soumya.
much. Actually, we shared this, we applied to ICMR, like they had called for world first challenge like that. So we applied, but this particular innovation looks too good to believe, you know. So I don't know
Absolutely,
what.
I agree. I even like this one because I've had a lot of cases of 30 weeks PPROM, 32 weeks PPROM, and then you feel so upset that okay, you're continuing them. But with this, if you can actually stop the PPROM, wonderful, and continue the pregnancy till say another 1 month, fantastic results. Fantastic results.
Continued up to 18 weeks, 18 weeks, 22 weeks extra. That's like a miracle.
Absolute miracle. Absolute miracle.
Thank you
Yeah.
so much.
With the chairpersons, any opinion of the chairpersons?
Do I go back to Zoom workplace?
Soumya ma'am, I wanted to ask one question. Like, do you need a fetal medicine person to inject, or we only can do it? Like, what gauge needle you use? And I just wanted to know because, see, in small towns we don't have people who are doing fetal medicine, no? Like,
Yes, yes.
so understand like what needle you use so that everybody
Yes,
will
so
know. Like, how.
there are two parts to your question, right? So
Yeah, yeah,
what what to use?
yeah.
That we use same amniocentesis needle,
Needle, huh?
22 gauge.
Hmm.
So the same thing. The
Hmm.
second question was whether we can do or we need a fetal medicine
Yeah,
specialist.
yeah, yeah. Huh.
This particular question I asked Dr. Hitesh Bhatt and renowned medical legal experts.
Hmm.
What they told was that, because as obstetricians, we are allowed to treat. We
Yeah.
do remember in case of thick meconium earlier we used to do amnio infusion and all, right?
Yeah,
So
yeah,
like
yeah.
that, because you are not taking any fluid out for
Huh.
diagnosis, you are
Huh.
only treating. You
Huh.
can always do it yourself. In case if there
Okay.
is like no person available in
Huh.
remote centers and all,
Yeah. Huh.
you need not always wait for that legally because you are not taking any fluid and not doing any diagnostic procedure. You can
Okay.
always go ahead and do.
Okay.
I think
Thanks.
Dr. Bhagia, your question was whether we need a PCPNDT for this procedure.
Yeah,
Was
yeah.
that it?
I wanted that also, and I wanted to know whether the normal gynecologist can do whether you like because usually all amniocentesis people who have done fetal medicine only should do, no, ma'am. That's why I just
So that is
wanted to know.
only
Yeah,
PCPNDT,
PCPNDT.
amniocentesis.
Yeah, 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 yeah.
Even if you've done fetal medicine and your center is not recognized by PCPNDT, you
Yeah.
cannot
You
for
cannot do it.
Yeah,
aesthetic.
yeah, yeah. That I know. Yeah, yeah.
Yeah.
Yeah, perfect. Thank you, Dr.
Okay,
Soumya.
okay, ma'am.
And
Thanks,
Can
ma'am.
I?
yeah,
Can
please.
I think can I? Me and Mysore, we are actually blessed, Dr. Nivedita. I must say that it's just one call away. So we've been trying with PROMs, and Dr. Soumya is a great help. And I must say that she also mentioned that there was one patient with IVF conception and 20 weeker, and she started leaking, but
That
then
was Sonia's patient
it was
only.
and she continued till 37, and my heart was bubbling. I said, I want to terminate this pregnancy because one was transverse and one cephalic. I said, we'll go ahead with an elective section. The patient was so comfortable, she said no, she wanted to continue this. So we encounter such kind of scenarios also. And I think the main thing what Dr. Bhagya Karthik was asking about is the consent is very, very important here. Because see, ultimately, when it is a precious pregnancy, they will resort to any kind of medical aid or assistance, which we will try to explain them and counsel them. So with good consent, I think we should get going.
Yes, yes. Thank you, Sonia. And also, I
Thank you,
wanted
Dr.
to
Soumya.
say
Yeah,
that
Dr. Soumya.
this has been registered in clinical trials registry, and we have taken ethics clearance. And also, we have applied for patent because this composition is new. So we are sharing the knowledge with everyone, but just like we don't want somebody else to claim that already, some places they have already started that we only did first time and all, to whom I have shared the protocol with on mail and all. So just for that sake, we have applied for patent. So
Perfect.
thank you so much.
Thank you, Dr.
Can I,
Soumya, and thank you,
Nivedita?
Dr. Bhagia and Sonia. Moving, yes,
Nivedita?
Dr. Patel. Yes, sir.
Yes, sir. So any gynecologist can do this by law. I am telling because in law it is mentioned Once you are having postgraduate degree, diploma, DNB, you are entitled to do any procedure related to OBGYN. Think you have taken special training, it's fine. Otherwise, it doesn't come in picture as far as legal part is concerned. One. Second part, just mentioned by somebody, PCPNDT. Naturally, we have to go for filling up the form F. And when it is invasive procedure, then we have to go with column C. There are 4 columns in form F, A, B, C, D. So B is for non-invasive and C is for invasive. So it is invasive procedure. So we will go with invasive. And one more form, that is form G.
G.
It is for invasive procedure. And that is why as far as PCPNDT part is concerned, form F, form G, we will have to go with. And as far as consent is concerned, it should be well explained to the patient and patient party that what it is and how successful it could be, because we cannot give guarantee, because in this type of situation now lot many studies we will be waiting for future to come with 100% guarantee to any patient. But till then we can advise them, if we do not do anything and if leaking continues, then this could be the probable outcome. If we go with this, we are taking chance. And if at all you are lucky enough, I am lucky enough as a your consultant, then there could be some miracle. And that way we have to counsel them. And with
Exactly.
all probable side effects, probable success rate, we have to explain. And then you can very well go with this type of procedure. It is always welcome step whenever it is in good faith of patient.
Yes, sir.
Thank you, sir. Thank you, sir. And we see a lot of thumbs up coming up simultaneously. I now, I mean, we're also mesmerized with this. So now we move on to the third session. Otherwise, we'll just never proceed. Handing over to the next coordinator for coordinating session 3, which is going to be a very nice medical legal talk by our own Dr. MC Patel, sir.
Thank you, Dr. Nivedita. And Soumya ma'am, it was really mesmerizing to see what exactly the new future upholds for the preterm and for PROMs. We move forward to the next session. Our chairperson is Dr. Suma madam. The first slide, please. Tech team. Change the slide, please. Yeah. Dr. Suma madam is a professor and unit chief. The previous slide, please. She is a professor and unit chief of Department of OBG at JSS Medical College and Hospital, Mysuru. She is also an undergraduate and postgraduate from the same college. She is a fellow of Karnataka College of OBGY, chairperson of the PG Board of Students in Surgery and Allied Subjects. She is a member of the governing council body of JSS Medical College and a member of Mysore OBGY Society. She is also an executive member of the KSC and AGOA. We welcome you, Suma ma'am. And our next chairperson is Dr. Sonia Mandappa, madam. She is presently the chairperson of the KCOG, president of the Mysore OBGY Society, founder and CEO of EVA Roots. The executive
We'll get going, ma'am.
Yes, ma'am.
Yes.
And
Thank
can
you
I
so
welcome
much.
Dr. Suma madam to please introduce Dr. Patel sir first.
Good evening, everyone. Thank you, Dr. Monica, for the kind introduction. We all know that MTP Act, which was which was started in the year 1971, it was amended in the year 2021. The most important features in that act, amended act, was we used to give indication for MTP as failure of contraception for married women. Now that has been changed and it has been included. The unmarried women were also included. And MTP up to 24 weeks, it has been amended for rape victims. And beyond 24 weeks, it is only for substantial fetal abnormalities. And most important thing is opinion of one RMP was required, will be required for pregnancy termination up to 20 weeks of pregnancy. And 2 RMP's opinion for pregnancy termination from 20 to 24 weeks of pregnancy. And we all know that we have to take the opinion of the medical board if we want to do the termination of pregnancy beyond 24 weeks. So to throw more light on this topic, that is MTP beyond 24 weeks of pregnancy, we have a very opted person for that. That is MC Patel sir. Apart from being a consultant obstetrician and gynecologist, sir is a medico-legal counselor. He is more, and I would like to stress here that he is very much instrumental and he has played a pivotal role in bringing out FOXI consent, uniform consent forms. And I would like to say also that that has been converted into, it is available in various local languages also, apart from English. And of course we always refer to those forms only, and he is a very good supporter of physicians in with respect to medical legal opinion. That is, sir is approachable 24/7, and whenever we talk to sir, he always says that if you want to have a very good sleep at night in respect to medical legal thing, you just keep my visiting card below your pillow and have a good night's sleep. So that is the assurance which is given by sir. And sir was vice president of Foxy in the year 2018. Now sir is contesting for the post of president. So all our votes to you, sir, and all the very best for your election. And sir has organized AICOG in the year 2017. And sir is the honorary member of Foxy PNDT and Violence Against Doctors and Regulatory Cell. And apart from being a gynecologist, sir has the credit of collecting 1,000+ eye pairs working with Red Cross Eye Bank. And he offers his medical services in Jammu Kashmir and Northeast states. And his main important motto is community service, and his vision is safe mother and safe child. Over to you, sir, for your talk on MTP beyond 24 weeks of pregnancy.
Thank you, Suma Madam, for kind words and all the good wishes in my election campaign. Thank you very much. Let me share my screen.
Sir, before you share your screen,
Yes,
we
yes.
should make mention
Oh,
that
yes.
you are Dr. M.C. Patel.
Yes.
That is, your name speaks it all. You are medico-legal consultant, your medico-legal counselor. So
Yes.
it comes with your name tag itself, sir.
Thank you, ma'am. So is my screen seen? Full screen?
Yes, sir.
Yes, sir.
Yes. So greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and President and Secretary of respective society who have joined this webinar. At the same time, I would like to thank all the societies of Foxy who have nominated my candidature for post of President Foxy, and due to that, I have got highest number of nominations in election process. So I am very much thankful to all the society who have nominated me, and now it is my humble appeal to endorse my candidature for post of President Foxy election year 2026, because my commitment is still there. Wherever you are, I'll be there, promise to reach the unreached. So seeking your blessings for post of President Foxy election year 2026. Voting is nearby. It will be starting from 1st of August, 10 a.m. and will continue up to 10th of August, 5 p.m. So coming to today's topic, MTP beyond 24 weeks of pregnancy, legal implication. Why I have selected this topic is very pertinent, and you will appreciate at the end of this lecture why this topic was very much important for discussion, because three friends of our from Maharashtra, Satara, they are facing very odd situation. They were behind the bar and they are suspended from their job, and they are facing legal implications in a case of termination of pregnancy more than 24 weeks. So is it worth discussing? Yes. And if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. And that is why these are some topics to be discussed at workshop or at CME or in conferences, to be updated as far as legal implications are concerned, and not to end up into any kind of medical legal problem. And if at all it happens, then how to get rid of it is our motto for discussion. Because ignorance of law is no excuse. Because as soon as any act, any law, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So merely on that ground that I didn't know these were the grounds for this provision for act, it doesn't stand in court of law, because it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse. What was the objective of MTP Act when it is enacted in 1971, mentioned by Dr. Suma Madam also? So when it is enacted in 1971, objective of this very act was to liberalize provision of termination of pregnancy, to protect registered medical practitioners who perform abortion as per provision under this act, and to keep record of women undergoing MTP very secret. So very important objective was to protect registered medical practitioner, because before 1971 MTP Act, to terminate pregnancy was crime. It was criminal offense, irrespective of anything. No excuse. Only excuse was if it was immediate necessary to save life of patient, and if you have terminated pregnancy just to save life of patient was the only indication available before this act enacted. And for that also you were under obligation to prove it, that whatever you did, it was just to save life of patient. So not to end up into this type of problem, this act was enacted, and to protect registered medical practitioner was the aim of this act. And for that, in section 3 of MTP Act, it is very specifically mentioned that notwithstanding anything contained in Indian Penal Code, a registered medical practitioner shall not be guilty of any offense under that code or any other law for time being in force if any pregnancy is terminated in accordance with provision of this act. So here word accordance is very much important. If you have terminated pregnancy in accordance with provision of MTP Act 1971, then only you are out of purview of any law, any code of conduct in this type of situation. So it is very much compulsory to terminate pregnancy in accordance with provision of MTP Act 1971. So MTP beyond 24 weeks of pregnancy, options and challenges and legal implications is subject for today's discussion. Can MTP be done beyond 24 weeks of pregnancy? So previously it was not allowed, because previously when this amendment came in 2020 and amendment rule came in 2021, before that, termination of pregnancy more than 24 weeks was not allowed. Only way was to go to Honorable High Court seeking writ petition for permission. And in one of the cases it happened when this permission was asked at 24 weeks of pregnancy. And when permission came from court, pregnancy was 32 weeks. So not to end up into this type of problem, in this amendment, government was kind enough to consider termination of pregnancy beyond 24 weeks of pregnancy, but only indication is congenital fetal anomaly which are incompatible with life of fetus. And in that very case, which just I mentioned, High Court had referred that very case to medical board only, but medical board took time to come to opinion from 24 to 32 weeks of pregnancy. So in this amendment, it was a very good amendment. But as far as opinion is concerned, we have to form opinion for termination of pregnancy. So when pregnancy is beyond 24 weeks of pregnancy, medical board can opine. What is medical board? One gynecologist, one pediatrician, and one radiologist or sonologist. Government may invite 2-3 more persons from private sector also, and that board will opine whether pregnancy can be or should be terminated or not. But very good amendment in 2021 rule is whenever medical board receives any application, any request for opinion, they are under obligation to opine within 3 days. So not to end up into same type of problem from 24 weeks to 32 weeks in that very case. So medical board is under obligation to opine within 3 days, and once opinion comes, that pregnancy can be terminated, then that very pregnancy should be terminated within 5 days. So these two amendments were very good in favor of patient. Opinion within 3 days and termination within 5 days. So with this, let us see how to deal with cases of termination of pregnancy beyond 24 weeks. Medical board will opine in Form D. It is prescribed form, that is Form D, name of woman, age, registration number, available reports and investigation. Whichever report medical board has referred to come to conclusion, they will mention everything in this. They can advise one more investigation also to come to conclusion if it is needed, and opinion by medical board whether termination is allowed or denied. And not only that, they will have to justify the decision why this pregnancy termination is allowed and why it is denied. And one more opinion medical board will have to give physical fitness of woman to withstand the termination of pregnancy, whether she is fit for termination, yes or no, and all the names and medical board with their designation and signature, date and time. So if patient comes with this Form D, then pregnancy can be terminated beyond 24 weeks of pregnancy. But in this, there is limitations also, because medical board can opine only in case of fetal congenital anomaly which are incompatible with life of fetus. So if pregnancy is very normal, say for example, if it is a case of rape victim and pregnancy is more than 24 weeks, and if pregnancy is very normal, medical board has no power. Medical board has no power to opine for termination of pregnancy, and in these cases one will have to go to Honorable High Court seeking writ petition for termination of pregnancy. But one more question, can registered medical practitioner do termination of pregnancy beyond 24 weeks of pregnancy without opinion of medical board or permission of court? Yes, there is provision in section 5 of MTP Act. If it is immediate necessary to save life of patient, irrespective of length of pregnancy, irrespective of center, whether it is registered or not, one can terminate pregnancy, but burden of proof will be on shoulder of the doctor to prove that it was immediate necessary to save life of patient, and whatever he did for termination of this pregnancy beyond 24 weeks to save life of patient, and if he can prove with records, then it is allowed under section 5, and no need to go for any formality of MTP Act, that is consent in Form C or form of opinion, nothing. You can straightway terminate pregnancy, but you will have to prove that it was immediate necessary to save life of patient. But now, very important part and discussion for today's topic, if pregnancy is more than 24 weeks and if baby delivers dead, nothing to worry, because in this type of situation, should we enter in stillbirth register? Yes. If it is more than age of viability, it will be considered stillbirth. Otherwise, it can be considered a abortion. So we will have to consider that, and we will have to enter into stillbirth. But when it is induced, then of course we have to consider, and it is to be entered and it is to be notified with authority also. So we have to notify birth, death, and stillbirth. And there are prescribed form for the same. Form 1 is for live birth, Form 2 is for death, and Form 3 is for stillbirth. So in this situation, when we are inducing termination, then unnecessary, there will be increasing in number of stillbirth, but it is compulsory by law. That is why if at all we are terminating pregnancy more than 24 weeks, we will have to enter into stillbirth. One more area, to whom custody should be given of that very stillborn baby? Naturally to the patient and patient party, but many a times they are not interested to take custody, and they may request hospital for final disposal. So in this situation, as per Act, Biomedical Waste Disposal Act, and their provision, we have to dispose that very body. We can give it to person who is taking care of our biomedical waste disposal under this act of our biomedical waste, and we will have to give certificate that that baby was delivered in our hospital stillbirth, so not to end up into any legal consequences on part of that very person who is going to deal with final disposal of that very baby. But very important part comes here. If baby delivers live, then what to do? Resuscitation not required, it's fine. If baby is healthy, straightway you can give custody to patient and patient party, it is fine. Should we enter in birth registration? Of course, yes, it is live birth. We have to notify with authority in Form 1. To whom custody should be given, just I mentioned, to the patient and patient party. If patient and relative are not willing to take custody, then what? In this situation, you can approach some good institution. They are taking care of this type of baby for adoption in eligible couple with all this legal formality. But in this, you will discharge patient like this. I was discharged with my baby. And then after all this legal procedure for adoption will start, hospital will not come in picture in that way. Of course, you can advise, you can guide them, you can make contact also of that very institution, but you will discharge patient with custody of their baby to them, not to end up into any kind of problem in future. If patient and relative are not willing for this, then can role of police comes? Of course, yes. You will inform police that this type of delivery happened to my hospital and patients and patient party are not ready to take custody of baby. But very important area, if resuscitation is required, then in this type of situation, when we have terminated pregnancy beyond 24 weeks of pregnancy, what should be the legal implications and what should be done? Is it mandatory? Yes. It is fundamental right of newborn. Once baby is not born, all the right goes with mother. Mother can take decision. But when baby delivers live, more than 24 weeks or irrespective of any gestational age, it becomes a citizen of India. And being a citizen of India, he has all the fundamental right under Article 21, life and liberty. So survival and health is his fundamental right, and right to life with dignity, including access to essential health care, essential newborn care, and proper nutrition. So if you fail to do this, then it will be big trouble. We will discuss it little later on. It is legal identity of baby. Once baby delivers live, it is a legal identity of baby and it is a citizen of India. Right to be registered immediately after birth, a name and nationality. Protection. This baby should be protected by law. That right to be protected from harm, violence, neglect, and exploitation. And family and care part is concerned. Right to be cared by their parents and to be nurtured in a loving environment. And as far as essential care on part of hospital is concerned, immediate care at birth, such as drying, thermal care, breastfeeding support, and continued care for health. So we are under obligation to do all this. Right against discrimination. So right regardless of race, gender, health status, and birth circumstances, we are under obligation to resuscitate this type of baby, and we have to be very careful in this type of situation. If resuscitation is required and not done, then you may invite punishable offense under section 299, 302, 304, and 304A IPC and newer version of Bharatiya Nyaya Sanhita. And it is very clear, passive euthanasia is not allowed, because if you do not do anything, if you do not resuscitate that very patient, it becomes a passive euthanasia and it is not allowed. There are only 2 cases decided by Supreme Court. In these very cases, Supreme Court has allowed passive euthanasia in famous case of Anuradha Sandbag and very recently, in few months back only, in case of Haresh Rana. Otherwise, passive euthanasia is not allowed. So you are under obligation to resuscitate that very baby. So in this situation, questions come: should we shift that very baby in NICU? Of course, yes. But in government hospital, there is no issue. We can very well shift patient in NICU. But in private setup, who will bear the cost of NICU? So in this type of situation, at the time of consent, we should be very clear with patient and patient party. Should one inform police? If patient and relative are not ready to ship baby to NICU, then you can inform police in this type of situation. Can prior feticide be considered? In other than India, in country where termination of pregnancy is allowed, it is compulsory to go for feticide before termination of pregnancy. In India, it is gray area as far as MTP Act is concerned. But when patient is major, when patient is mentally sound, she can take decision for feticide also. And law doesn't teach you medicine how to manage any case. That is up to you, and you can very well consider feticide if patient gives consent for the same, and if patient is major and mentally sound. If patient is minor, guardian can take decision for feticide prior to termination of pregnancy. And why we kept this discussion for this particular case, which happened just 2 months back in state of Maharashtra. Case was like this. It happened in month of March 2026 only. So in that very case, patient was minor. She was 17 years age. Pregnancy was 26 week or 26 week plus. So she went to medical board for opinion for termination of pregnancy. But pregnancy was very normal. Medical board had no power. So medical board refused to give permission for termination of pregnancy. So she approached Honorable High Court, Maharashtra, Mumbai, and this Kolhapur bench. This Honorable High Court gave permission to terminate pregnancy, and they instructed Government Hospital of Satara to admit this very patient and to terminate pregnancy in good hygienic condition with taking all care and caution. And they were instructed to inform High Court after termination of pregnancy. Patient was admitted, termination was initiated, and that termination was failed. But very next day morning, she aborted and baby was live. They didn't do anything to that very baby, considering that she was interested in termination of pregnancy, and that is why she approached medical board, and that is why she approached Honorable High Court. So they didn't do anything. They didn't resuscitate baby. They didn't give any nutrition. And when this abortion happened in morning, and baby succumbed in evening at 7 p.m. or so. Now, tragic story comes. That very patient filed a complaint against that gynecologist, superintendent of that very hospital, and member of medical board who had opined not to give permission for termination of pregnancy. And her plea was that they didn't resuscitate my baby, they didn't give any nutrition to my baby, and they left my baby to mercy to die. And High Court was very serious. High Court ordered to suspend all these 3 doctors from their duty, and they requested Government of Maharashtra to file complaint against this doctor, file FIR considering Section 302, Section 304, and Section 304A. Now imagine the situation. If this case is proved in court of law, then they will be in big trouble because there is a provision of imprisonment for lifetime. So, of course, we 3 medical legal expert has advised them and preferred appeal in higher fora. We are quite hopeful there's some good result will become in favor of all our 3 doctor friends. But in this type of situation, not to end up into this kind of problem, we should be very careful. This is the same case just I narrated. So there is always a way. So how to prevent with all these carry home messages? Just I mentioned, we have to terminate pregnancy in accordance with provision of MTP Act 1971, not to end up into purview of any law, any ordinance, any code of procedure time being in force in India. So we should be very careful. And as far as pregnancy more than 24 weeks is concerned, proper counseling before termination of pregnancy is very much vital. We will have to inform that it is likely that baby may come alive, and if baby come alive, then this will be the procedure, and you will have to bear cost of all this, and you will take custody of that very baby. And this type of consent is there, and even if patient doesn't follow or doesn't comply, then you can very well inform police, not to end up into problem just our three friends are facing. Because medicine is science of uncertainty and art of probability. Problem with world is that intelligent people are full of doubts while stupid ones are full of confidence. We have to decide where we stand. This gentleman have so many staircases, but he doesn't know how to use them. It doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So if you want to sleep like this, take tender care of your patient, comply with the provision of law, pray Almighty God before going to sleep, and keep my visiting card below your pillow. With regards, salute to all. And before I can conclude, accessibility is not checkbox. It is mindset. And I am committed to be accessible always to everyone. And I am committed. I am accessible as on today also, and I will be in future also, because my commitment is still there. Wherever you are, I will be there. Promise to reach the unreached. So seeking your blessings for post of President Foxy, election year 2026. Election will be from 1st August to 10 August. It is a job of only 1 minute. Please spare 1 minute for democracy, 1 minute for Foxy, and 1 minute for me to cast your precious vote. Each vote matters, and each vote is precious for me. Thank you very much. Please do not assume. Please ask if any query, any questions, if time and chairpersons permit. Thank you very much.
Thank you very much, sir. Very nice. And your talk is always like hitting the nail on the head. It is always on dot, on point, will be very much clear. Anyone will not be having any doubt. So only thing that even I wanted to tell, sir, we had to terminate a pregnancy between 23 to 24 weeks of pregnancy. It was a twin pregnancy. And both the babies were alive. One was 500 plus grams and another was 600 grams. So they wanted us to resuscitate. Of course, as you told, we all took proper consent, explained to them, and even NICU people. Of course, babies succumbed. One baby succumbed within 1 hour. Another one died after 1 day. But as you told, information. I always tell my students, we have to remember 2 letters in our life. That is taking that explanation, that consent, taking the consent, and whatever we explain to them, the documentation of that more important thing. Thank you very much, sir. Sonia, over to you.
Yes, sir. Also, sir, Dr. Patel, sir, always in his messages and WhatsApp messages also communicated two things. He says always two things define you: your patience when you have nothing, and your attitude when you have everything. This is actually a message to be communicated to each and every Foxian. Of course, you have already reflected that Foxy need leadership that can bring together clinical excellence, ethical practice, professional security, and a collective strength. And we have listened to your talks, and we know your vision and your priorities, we know. And then we look at your roadmap for the future of Foxy, sir. All the very best for your candidature. All the support is with you, sir. Thank you very much.
And just to clarify, I am obstetrician and gynecologist. Even today I do cesarean, I do hysterectomy, but I have developed this branch and it was need of time. When I did my LLB and LLM, I am postgraduate in law also and with criminology. At that time, I never thought that it will be compulsory for me also to be in this field. But when these CPA cases were increasing in number, and after this PCPNDT, our
Correct.
Foxian friends were harassed like anything, and that is why I came in this field. I started this practice. I am appearing in CPA and in PCPND on behalf of doctor, and I have decided principally not to appear against doctor. I always appear for doctors. It is my principal decision and in my practice. So it was need of time, and that is why I have developed that very field. So you have seen hardcore obstetrician as a Foxy president. You have seen hardcore endoscopic surgeon as a Foxy president. You have seen IVF specialist as a Foxy president. Now you see
Medical
obstetrician
legal,
turned
yes.
into medical legal expert as a
Yes.
president Foxy. Thank you very
Yes.
much.
Thank you
Sir,
very much, sir.
just a last minute question, sir. The
Yes.
case which you actually spoke about and narrated the whole story,
Yes.
the OBGYN, I think, has done the best because that was a notice received for termination. So what
Agreed,
else they
but
could have done, sir,
when
otherwise?
agreed, everything was fine. But when baby came alive, delivered alive, they didn't do anything. Considering that she is not interested, she had approached medical board, she had approached Honorable High Court, so she
They
might
should,
not be interested in baby. So they didn't resuscitate. They didn't give any
Correct.
nutrition also.
Correct.
And the tragic part is patient herself filed a complaint.
That's
Then
what.
they didn't resuscitate my baby, and that was the matter for concern. And that is why this High Court Mumbai Kolhapur bench came up with this decision. And all these three doctors were suspended, and they were put behind the bar. Of course, with approach, they are out of bar with bail, but they are facing this litigation. And let us see, let us be hopeful that they all three should be out of all this problem.
That is
But
why, sir, we need not have to believe anyone. Whatever we
yes,
are,
yes,
we can't suspect or think that she might not file a case. So you
yes.
always tell
Don't
that
assume.
after
Correct.
obstetricians in India are having Mother Teresa attitude, Ayo Papa attitude. So we have to forgo with that. Whatever we explain, we should document it, get their signature, and we have to play a safe game.
So
I don't see
if
any question in the chat box,
everything goes
sir.
fine, it's fine. But if at all something goes wrong, then it becomes
Ah,
very difficult to face. Of course, we are
Yes.
advising all these three doctors, but even then, till final judgment comes, it will be a scary situation for this doctor.
Was there a scope that they could have taken a consent that even if there is a baby delivered
No,
live,
no.
we have to do our thing.
You are
No.
because passive euthanasia is not allowed. Na?
No, in case if you have taken a consent also for that situation,
Then
how we be
also,
safe, sir?
can you withdraw support if patient herself, in young patient I am telling, say that I do not want to live and let me die. Can you remove all this support? No. In eye of law, passive euthanasia
No.
is not allowed. So even if you have not resuscitated, then also in case paper, there should be mentioned that you had resuscitated.
Exactly. Correct. Yes, sir.
Thank you
Yes.
very much, sir.
Thank you very
for the
much.
opportunity also.
Yes.
I don't see
Thank
any questions in the
No
chat box.
questions.
So I don't think, sir,
Okay.
with your talk, there will be any doubts.
No
sir.
questions.
Thank you very much, sir.
Oh, yes.
And I feel very much privileged that I am chairing your session. Thank you very
Yes.
much, sir.
Welcome.
Over to the
Thank you, Suma
over
ma'am.
to Dr. Monica.
Yeah, we will move on to the panel, ma'am. Yes, thank you, Suma ma'am.
Yes.
Thank you,
Thank
Sonia
you.
ma'am, and thank you, MC Patel sir. Once again, requesting all of you to please vote and support for MC sir, and encourage maximum members of your society to come ahead and do the voting. We will move
Yeah,
on
of
to the
course.
panel discussion. It's on acute kidney injury in obstetrics. We have Dr. Rupa ma'am and Dr. Pushpalata ma'am as our moderators. Dr. Rupa ma'am is the past president of the Mysore Obs-Gynae Society and has been an assistant professor at KMC Manipal and former professor and unit head at JSS Medical College. Welcome, ma'am. And we have with us Dr. Pushpalata Kiran ma'am as the next moderator. Ma'am is the past secretary of Mysore Obs-Gynae Society and right now consultant at Kamakshi Hospital and Supreme Multi-Speciality Hospital. Welcome, ma'am. We have Dr. Himamani ma'am and Dr. Sudha ma'am as our expert panelist. Dr. Himamani ma'am is a senior nephrologist at Mysore. Ma'am is the professor and HOD of the Department of Nephrology at Krishna Janmanani Super Speciality Hospital and Mysore Medical College and Research Institute. Welcome, ma'am. And we have with us Dr. Sudha R. ma'am as the next expert. Ma'am is the president of the Mysore Obs-Gynae Society, former medical superintendent of the Chelamamba Hospital, Mysore, and former HOD at MMC and RJ Mysore. Welcome, ma'am. We have a vast team of panelists with us today. Firstly, we have with us Dr. Lepakshi. Dr. Lepakshi has been the assistant professor at Ambedkar Medical College and has been the professor and HOD of Shimoga Institute of Medical Sciences. Currently is the HOD of the Subbiah Institute of Medical Sciences, Shimoga. Welcome, sir. Next, we have with us Dr. Jayashree Patil. Dr. Jayashree Patil is consultant at Kadale Multi-Speciality Hospital, Humnabad. Welcome, Dr. Jayashree. Then we have with us Dr. Priyanka. Dr. Priyanka is the secretary of the Basaf Obstetric and Gynecological Society and chief consultant and IVF specialist at Jeevan Jyoti Mother Care and IVF Hospital. Welcome, Dr. Priyanka. Next, we have with us Dr. Jyoti ma'am. Dr. Jyoti ma'am is a consultant at Vasaf Kalyan, Bidar district, Karnataka, and is a senior consultant with over 25 years of experience. Welcome, ma'am. Then we have with us Dr. Priyamvada ma'am. Dr. Priyamvada is the chief consultant at Unity Hospital at Shivamoga, has been the past secretary of the Shimoga Obs-Gynae Society. Welcome, ma'am. Then we have with us Dr. Savita Rathod. Dr. Savita has been trained in hysteroscopy, laparoscopy, and gynecological surgeries, as well as robotic surgery and cosmetic gynecology. Currently working at Narayana Health Hospital, Mysore. Welcome, Dr. Savita. Then we have with us Dr. Pooja Prakash, ma'am. Dr. Pooja Prakash, ma'am, Dr. Pooja Prakash, ma'am, practices as Karnataka, Bangalore, and is one of the senior consultant gynecologist over there. Welcome, Dr. Pooja. Then we have with us Dr. Panura Gaya sir. Sir is a society of the Chikmagalur Obs-Gynae Society and presently working as an associate professor at Chikmagalur Institute of Medical Sciences at Chikmagalur. Last but not the least, we have with us Dr. Soumya Patil. Dr. Soumya ma'am is a consultant, laparoscopic surgeon and fertility specialist at Motherhood Hospital at Mysore and is the Foxy state coordinator for the REACH CME of Karnataka. Welcome, Dr. Soumya. Over to you, Rupa ma'am and Pushpalata ma'am.
Can you hear me? Hello?
Yes, ma'am, we can hear you.
Okay, I just share my screen. Meanwhile, thank you very much, sir, for giving us this opportunity to share this panel's discussion. I have a good team who will answer all the queries. I wish, sir, best wishes in the upcoming election. The incidence of acute kidney injury about 1 to 7% in developing countries, and it's only about 120,000 in developed countries. Just give me some time. I'm not able to log in.
Ma'am, we can see your screen, we can see your WhatsApp. So if you minimize the Zoom link, maybe you can get through and open the presentation. Because we can see your WhatsApp.
Ma'am, just zoom this page and you go to your presentation, ma'am, because your screen is visible. We just need to see your presentation.
Yeah, now minimize the Zoom.
Yeah, 1 minute.
Okay, I think.
Can someone guide me? No, I'm not able to share the screen. Excuse me?
Ma'am, we can see
screen
your
is
screen
open.
now. Just share the presentation.
Madam,
Yes.
name screen open agida ma'am ಈಗ. Yes, madam.
Yes,
Go to
ma'am. Yes,
go to
yes.
slideshow. Go to slideshow from beginning. From beginning go to yes. Yes, yes.
Yes, ma'am.
Anyway, I have a good panelists who are from all parts of Karnataka. We have a nephrologist among us who is working as an associate professor in Ramaya Medical College. And the incidence of AKI is about 1 to 7% in developing countries. And it is as less as 1 in 20,000 in developed countries. So anatomically, all of you know that either because of compression of the graviduterus or because of the relaxing effect of progesterone, hydroureteronephrosis in pregnancy is quite common, more so on the right side.
So during pregnancy, the kidney undergoes During pregnancy, the kidneys undergo notable structural adaptations, including increase in the overall length of about 1 centimeter and 30% rise in the kidney volume, which is an increment in both vascular and interstitial fluid compartment, and as well widening of urinary collecting system. There is a physiological hydronephrosis because of mechanical compression by enlarging uterus and also due to the smooth muscle relaxing effect of progesterone. The urinary stasis predisposes pregnant women with asymptomatic bacteriuria to develop acute pyelonephritis.
Dr. Lepakshi?
Yes, madam.
Systemic changes relevant to kidney in obstetrics.
Yes, madam. Actually, we do see an increase in the cardiac output almost by 50%. And there is also an increase in plasma volume by 30 to 40%. There is also an increased peripheral vasodilatation and because of the nitrous oxide, prostaglandins, and relaxin. And we also see a decreased systemic vascular resistance. There's a modest fall in blood pressure and widening of pulse pressure in the first and second trimesters, and which normalizes in the third trimester. There's also an increased renal blood flow of almost 70 to 80%, and an increased GFR to almost 40% by the end of the first trimester. There's an increase in proteinuria, which is equal to or less than 300 milligrams per 24 hours, not significant in pregnancy.
So there are a lot of anatomical changes, physiological changes, and systemic changes which throw a lot of load on the kidneys. Dr. Pooja, what happens to renal function in pregnancy? Is there any alteration in the renal function in pregnancy?
Good evening. This is Dr. Pooja. I'm a nephrologist practicing at Ramaya Medical College. Definitely, there will be a hyperfiltration that happens in pregnancy. So we can see that a GFR of 90 ml per minute per 1.73 meter square This is an estimated GFR. Usually Indians will have a GFR of around 80-85, but by around with the pregnancy the GFR increases. Though we have serum creatinine, which is a marker which is currently used to calculate the GFR. GFR is the creatinine which is measured has to be a little lower in pregnancy. So what we should understand here is, because of the hyperfiltration, the serum creatinine will be at a lower level in pregnancy. So any creatinine measured during pregnancy, if it is more than 0.8 or 0.9, should raise a suspicion of renal impairment. Even though in recently probably serum creatinine has been is being routinely evaluated in pregnancy, but as such in the national health guidelines, I'm not sure till I was doing my MBBS, serum creatinine was never being checked in the first trimester. So 24-hour urinary creatinine clearance, if we see, it will be very high. So it has to be high. There will be a hyperfiltration, which we should know. Definitely, there will be some amount of protein leakage that will be there with the PCR, urinary albumin creatinine ratio of a little more, that is 30 milligram per gram. So what as obstetricians you all have to know, and what we as nephrologists would seek from you all is to get a renal function test in the first trimester.
To summarize renal function test, we have glomerular filtration rate, blood urea, serum creatinine, uric acid, electrolytes, urine protein, urine creatinine, albumin ratio.
So with so much of changes in the renal system, now it's mandatory that we do a serum creatinine. That's the smallest thing we can do for all patients in first trimester itself, to screen patients for abnormal renal function. Dr. Savita, do you routinely do renal function test in pregnancy? Dr. Savita?
Hi, madam. Good evening, everyone. Yes, ma'am. We routinely don't do as far as serum creatine or whatever test available during pregnancy in the low risk patients. Rather than that, we assess the renal health assessment can be done by doing a simple dipstick test or the routine blood pressure recording and all, and it has to be monitored. But in high risk cases, like patient who is pregnant with CKD, she is already a chronic kidney disease, or she has underwent a renal transplantation, or the patient is already a diabetic or a hypertensive along with it, she has to undergo routine renal function tests, as well as some of the immunological diseases, autoimmune diseases like SLE. They have to undergo a routine trimester wise the renal function test has to be done, even in the advanced maternal age also. Women on ART, having ART pregnancy, as well as the multiple pregnancy also. Especially very important if the lady had a previous history of preeclampsia, in them also a routine renal function test has to be done.
Yeah. So you're very correct. You have to do in all cases, but in high risk cases, you are more vigilant, and maybe you would repeat more frequently to see if there is any alteration in the renal function.
Yes, madam.
So, Dr. Priyanka, can you just tell us what is Praki and why is it important?
Good evening,
Dr.
everyone.
Priyanka?
Good evening. Yes, ma'am. Good evening, everyone. Thank you for this opportunity to share the platform with all the seniors. So coming to the question, Praki. So it's a pregnancy-related acute kidney injury. Indicates there is an abrupt decrease in the function, and also there is a structural damage to the kidneys. So which is seen more commonly in the developing countries, just because of the postpartum sepsis, because of the post-abortion sepsis, because of lack of antenatal care, and few of the patients landing up in pyelonephritis. So incidence was very high previously. So when we had seen it in 1960s, it was around 20%. In 2000, it has dropped to 5%. But now in 2025, according to the all studies, the percentage of the incidence has come to 2%. So drastically, there is a decrease in the incidence. And now why it is important is it contributes to almost 25% of the maternal mortality and 30% of the chronic kidney diseases who land up in end-stage renal disease. And 20% of the patient also land up in dialysis dependent condition. So it is important to know about PRAC.
So knowing about pregnancy related AKI is very important, because if you can detect the kidney disease earlier, you may be able to reduce maternal mortality, perinatal mortality, and also progression of the disease. Is very, very important. So Dr. Pooja, how do you define acute kidney injury?
Yeah, yes. So acute kidney injury definition is very important. So it is defined as a rise in serum creatinine by more than 0.3 milligram per deciliter over the last 48 hours, or an increase by more than 1.5 times the baseline in the last 1 week. So if we have a creatinine which is already done previously, yes. Or if there is a creatinine which was done earlier, then a comparatively an increase by 1.5 times, we consider it as an acute kidney injury. Or if at all the creatinine has come abnormally high, then for all practical purposes, it is considered as an AKI or an AKI on a chronic kidney disease.
Yeah. These
There
are
are
the
several
classification systems, but what we now use is the KDIGO classification. Can you just throw some light on this KDIGO?
Yeah, so this is KDIGO classification of acute kidney injury, which has made it very simple. So it is classified into 3 stages: stage 1, stage 2, and stage 3. So stage 1 is the rise in serum creatinine by 0.3 milligram per deciliter within 48 hours, or what I told earlier, 1.5 times the baseline, presuming that everything has happened over the last 7 days. But there will be a lag period during which the creatinine might take some time to go up. So it almost takes 48 hours from the initiation of injury to the creatinine jump. So that is where this urine output criteria helps us. So it is the urine output which starts decreasing, that is the oliguria sets in first rather than the rise in the serum creatinine that we see. Hence, urine output of less than 0.5 ml per kg per hour for 6 hours can also be considered as stage 1 AKI. Stage 2 AKI is when creatinine is 2 to 2.9 times the baseline. Stage 3 AKI is when the serum creatinine rises 3 times the baseline, or any serum creatinine of more than 4, or initiation of dialysis becomes a stage 3 AKI. So this is how we classify AKI, and the AKI in PRACI is also defined the same way.
So the level of serum creatinine, the rate at which the serum creatinine is increasing, and the urine output and requirement of renal replacement therapy, all these are to be taken into consideration to stage KDIGO. If it is detected in stage 1, prognosis will be better. If it is in stage 3, prognosis will be not so good.
Yes.
Dr. Priyamvada, so when do you say the creatinine levels are abnormal?
Hi, ma'am. Good evening. Creatinine levels, when it increases more than 0.8 milligram per dl consistently, or when there is sudden increase of 0.3 milligram or from the baseline level, then there, we call it as abnormal creatinine levels. And also when there is a failure of creatinine to decrease in early pregnancy, because it falls during early pregnancy. And if there is a progressive upward trend in serial measurements, or if creatinine levels approaching or exceeding pre-pregnancy value, then we call it as abnormal creatinine level.
Yes. So it's very important for us gynecologists to know that AKI can happen in any case, especially in high-risk patients. And it's very important to assess renal function right from the beginning of pregnancy. And when exactly we say that the kidneys are getting injured. Now the terminology of renal failure is gone. It is more known as kidney injury, either acute or chronic. Now, Dr. Jyoti, what exactly happens in AKI? What are the kidney changes that can happen in acute kidney injury? Dr. Jyoti?
Yes, ma'am. Thank you for the opportunity, ma'am. Good evening, everyone. Acute kidney injury, it is not a single disease. It is a syndrome where there is a sudden fall in GFR due to structural injury to different parts of the kidney. And this particular diagram demonstrates the pathological spectrum of AKI in pregnancy. Nearly 50% of the cases show acute cortical necrosis where there is irreversible necrosis of the renal cortex resulting in permanent loss of nephrons. And about 18% have acute tubular necrosis where prolonged hypoperfusion or toxins injure the tubular epithelial cells resulting in potentially reversible lesion with timely intervention. Then 13.5% of the cases will have thrombotic microangiopathy, which results from endothelial injury. And about 10.5% of the cases will show glomerulonephritis due to immune-mediated glomerular inflammation, while acute tubulointerstitial nephritis, which contributes to 3.75%, is caused by drugs or infections producing interstitial inflammation. So in
why
essence,
this is important is
why in
nearly
essence
50% of the biopsy, if at all it is taken, shows acute cortical necrosis. We don't like this. Patient should not get into this phase of acute kidney injury because more often this is not reversible. A tubular necrosis is reversible, but cortical necrosis is not reversible. So we should somehow find out whether there is any chance of kidneys getting injured, screen them, diagnose early, and promptly treat them to reduce the chances of cortical necrosis. So, Dr. Jayashree, we're talking so much about acute kidney injury. What are the causes for acute kidney injury in pregnancy?
Hi, ma'am. Good evening, everyone. I'm Dr. Jayashree. So, the most common cause of pregnancy-related acute kidney injury in developing countries is sepsis. It may be septic abortion, puerperal sepsis, or repeated UTI, pyelonephritis, and other cases includes hemorrhage, that is antepartum hemorrhage or PPH. And severe preeclampsia, HELP syndrome, they can also go rapidly into AKI. And other causes are acute fatty liver of pregnancy. And thrombotic microangiopathies like TTP and HUS also leads. And other systemic causes are SLE. And we should be carefully use NSAIDs who are at a risk of AKI because the NSAIDs, they also cause AKI when it is high risk.
So, Dr. Lepakshi, diagrammatically, can you just repeat the causes for pregnancy-induced AKI in developing countries? Because it is
Yes,
different
madam.
from developed countries. What are the common causes in developing countries?
In developing country, we have this preeclampsia and eclampsia, madam. They rapidly, sometimes they go in for this AKI. Then we have this hemorrhage, either in the form of antepartum hemorrhage or postpartum hemorrhage. Immediate intervention, they should, it should not be delayed in looking into the cause for the bleeding, and immediately we have to attend to it. Then we have this puerperal sepsis, madam. And if this post a bottle, also they are they can go in for this the AKI. Then we have this pyelonephritis or the retained products of conception if the evacuation is not complete. Then we have this abdominal wounds and the episiotomy wounds where they are not covered with any antibiotics. They can immediately go in for the sepsis. So sepsis is a main cause for this AKI. Then we have this acute fatty liver of pregnancy, which we have seen. They, if it is not identified, they go rapidly into that AKI, madam. Then we have this hemolytic uremic syndrome, which again they can go in for this AKI. Then other diseases also include this malaria, dengue, the snake bite. We have seen even cases going into rapidly progressing into AKI, madam.
So
And of course,
if you observe this diagram, you see
yes, ma'am.
sepsis, hemorrhage, and preeclampsia as the
Yes.
major cause for acute kidney injury in pregnancy, and this is so for maternal mortality also. Maternal mortality also,
Yes.
sepsis, hypertension disorder, and hemorrhage are the commonest contributors. So probably acute kidney injury is one of the route for maternal mortality. So there was a study in our own country where the incidence was 1 to 12%, and common causes were sepsis, hypertensive diseases, and bleeding. And it is disheartening to know that the perinatal mortality was 20 to 67%. Rate of prematurity was 13.9 to 58%. Maternal mortality was 2.4 to 34%. And 8 to 30% of these women were dialysis dependent, and they went in for chronic kidney disease in 15 to 51%. So there is a huge responsibility on the part of the obstetricians to reduce maternal mortality, perinatal mortality, and morbidity by screening, early diagnosis, and prompt treatment of acute kidney injury in pregnancy, so they can go home a healthy baby and a healthy mother. So
after knowing the acute kidney injury causes, Dr. Savita, can you tell us what are the complications of acute kidney injury?
Yeah, complications can be both maternal and the fetal complications. So coming to the maternal complication, it raises to maternal death about 13 to 15%. And it leads to a longer ICU stays because of the recovery of the mother. And there is an increased risk of LACS, that is 1.5% fold, because we may acute kidney injury leading to complications like abruption or preterm labor. So increased risk of LACS is there. There is always a risk of hemorrhage about 1.3 fold, mainly due to the raised blood urea level, which causes uterine vascular endothelial damage with atherosclerotic changes with release of massive inflammatory mediators. So there is an increased risk of bleeding tendencies. So they are more prone to develop abruption placentae. And as a result, severity, it may go up to HELP syndrome. There may be a need of dialysis about 32%. Also, the mother can end up with the end stage renal disease about 2.4%, and about 4% may also require dialysis even after delivery. Coming to the fetal complications, since there is an increased complications, the fetus may have a low birth weight or a premature birth, as well as the stillbirth is also seen. So these are the complications of acute kidney injury during pregnancy.
So many complications, and especially need for dialysis is increased 32-fold. So that is a huge number. So it is our responsibility to somehow see that we screen them and treat them early. Dr. Pooja, from AKI, either they recover or they progress into chronic condition. So when do you say that the patient has completely recovered or partially recovered? How do you say?
Okay, so this complete recovery and partial recovery, even though it's been defined as a serum creatinine of less than 1.4 at the time of discharge or on a follow-up basis, any lower creatinine, we are very happy. So even at a creatinine of 1.4, the GFR will not be the same as creatinine of 1 or a creatinine of 0.9. But still, to some extent, we can say that there is a complete recovery with the creatinine of less than 1.4. Whereas partial recovery means there is an improvement, but then it's a subnormal improvement. So whenever there is an injury to the kidney, the part of the filtering nephrons get damaged. So what will happen? The rest of the nephrons will have to do their job a bit more. Say even if there is a complete recovery, the serum creatinine improved to 1.4, still we have to be watchful. Any one episode of acute kidney injury, even not just a prachi, any episode of acute kidney injury will leave some nephrons dead. So though we have so many nephrons in each of these kidneys, there will be a few nephrons which may not be functional, and it is the other nephrons which do hyperfiltration and try to manage the show, and thus the creatinine improves. So every episode of AKI is like every episode of acute coronary syndrome. Even though the patient improves out of the heart attack, still there will be some damaged muscles. Like that, even though the patient improves from the acute kidney injury, still there will be some amount of nephrons that she would have lost. So complete recovery and partial recovery are decided like this. Dialysis dependent state means if the patient remains anuric. Anuric means urine output of less than 100 ml per day, or patient requires dialysis at the time of discharge, or patient is still having a urine output of less than 400 ml per day and with a rise in serum creatinine. It's almost like if we do dialysis today, it takes another 5 to 7 days for the serum creatinine, the original kidney, to manifest its serum creatinine, because once we do dialysis, the serum creatinine will reduce. Obviously, it will come down. So if we have to know what is the functionality of the kidney, we need to keep the patient without dialysis for almost 5 days. By then, we will actually know what is the kidney functionality. If the patient's serum creatinine remains higher despite 5 to 6 days without dialysis, then the patient is labeled as dialysis dependent.
Very good. So from this, they can either completely recover or partially recover, requiring follow-up, or they may become dialysis dependent even after 3 months or 12 weeks of delivery. But very rarely they can face death also if not treated on time and in a good setup.
We came to know that sepsis is the major cause for acute kidney injury. Dr. Priyanka, can you tell us the clinical course associated with sepsis acute kidney injury?
Yes, ma'am. So in the present slide, we can see the clinical course of the sepsis associated acute kidney injury. So what happens from the time of patient develops sepsis until the recovery or any other long-term outcomes we can see here. So when sepsis develops because of postpartum sepsis or because of septic abortion or because of pyelonephritis, the infection causes a decreased blood flow that leads to inflammation, endothelial injuries, and tubular damage. As a result, the acute kidney injury develops. So for this, early treatment is very critical. We have to recognize early sepsis, give prompt antibiotics within 1 hour of that. Fluid resuscitation is very important. We have to avoid nephrotoxic drugs, give proper hemodynamic support, and monitor urine output and creatinine, because this is a stage where we can prevent the progression of the disease. So the diagram also shows about the outcomes. So depending on the severity and response to treatment, we have several pathways shown in the diagram. So here, complete recovery, as Pooja madam said, kidney function can return to normal, which is the best outcome. Or sometimes patient can land up in partial recovery, where kidney function improves but does not return completely to the baseline. So patient requires frequent follow-ups. So even few patient can land up in relapse of acute kidney injuries, where kidney injury improves initially but later recurs due to persistent or recurrent infection. So few patients can also land up with no recoveries, where AKI can persist in spite of the treatment. So even in the diagram, we can see there is a long-term sequences where the persistent kidney injury can progress to acute kidney disease, which can last, where the kidney dysfunction lasting from 7 to 90 days. Even few patients can land up in chronic kidney dysfunction, where dysfunction can persist for more than 90 days. So even there is a higher risk of recurrent AKIs, higher risk of Hello? Hello? Hello?
Yeah, we can hear
Hello?
you, Priyanka.
Yes, ma'am. So bottom of the slide is we have to do the early diagnosis, because AKI is a dynamic process. If we diagnose sepsis early, we start antibiotics promptly, optimize the fluids, provide proper organ support, patient recover completely. If we delay the diagnosis, then it can increase the risk of persistent kidney injury, which can progress to a chronic kidney disease or even the death. So early recognition, early antibiotics, early resuscitation, and early nephrology involvement can lead to better maternal and renal outcomes.
Correct. So thank you very much. So this is what actually happens. They can recover, they can progress to AKD, they can progress to CKD, they can, it can result in recurrence of AKI, or they can die. So this much in a nutshell of what are the causes, when to screen, how to screen, what happens to renal function, what are the possibilities if there is acute kidney injury. So to just make it more interesting, we have a case.
Mrs. X, age 29 years. She's gravida 4, para 3, leaving 2 and death 1, with 33 weeks of gestation and 5 days, with cephalic presentation with severe preeclampsia. She had a regular ANC, diagnosed to have an hypertension at 30 weeks of gestation, with a BP of 160/100, and she was started on labetalol plus idursulfase. Now she has been admitted at 1:30 p.m. She is conscious, oriented, PALA 2+, bilateral pedal edema 2+, with a BP of 140/80, afebrile, serious RS, nothing abnormality detected. She is 34 weeks on per abdominal examination. It is tense, tender, and fetal heart rate is absent. The cervix uneffaced, and the present part is higher. Dr. Priyamvada,
what is the diagnosis, Dr. Priyamvada, at this part?
Looking at the history, we can consider it as a severe preeclampsia with
uterus is tense, tender, FHS absent.
Looks like abrupt shock.
Yeah. So in this case, what investigations would you like to do?
At this stage, I would like to do CBC complete hemogram along with the blood group, PT, APTT, INR, renal function test, and LFT.
Yeah. So the tests were done. And here, what were the abnormalities? Could you just enlighten us on that?
Yes, there is a fall in HP level, maybe because of hemorrhage, concealed hemorrhage. And the total count also raised. Looks like she is going into sepsis, and the platelet count is reduced. That is 96,000. INR also slightly increased, and creatinine level is also raised. And bilirubin level.
What do you think is the diagnosis here? What has happened? In addition to abruption, what else has happened probably?
Going into DIC.
Yeah. So she's gone into HELP syndrome, and it's our duty to deliver her. And under GA, section was done. Baby was dead, 2.4 kg, with concealed blood clots of 750 grams. Puvillary uterus was present, as you see in the picture. Atonic PPH was managed medically, plus uterine artery ligation bilateral, and hemostasis was good.
After 6 hours post-op, these are the investigations and the findings. Dr. Jyoti, can you tell what is abnormal in this?
Yes, ma'am.
What has happened, Dr. Jyoti?
Yes, ma'am. There is a severe hyperkalemia which can be life-threatening. That has to be treated immediately, even along with the treatment for the acute kidney injury.
So platelet count has further reduced.
Yes,
creatinine increased, urine output has dropped, and LDH has increased. So what was done for her was?
We transfused 3 pints of PRBCs, 2 FFPs, and 2 cryos, and 2 random donor platelets and 1 single donor.
Yeah. So Dr. Jayashree, could you tell us about what is massive transfusion protocol?
Yes, ma'am. Massive blood transfusion.
We might need a massive transfusion.
Yes, ma'am. Massive transfusion protocol is mainly used in hemorrhagic shock, and we call it as massive when we transfuse 10 or more than 10 units of PRBC within 24 hours, or 4 or more than 4 units of PRBC in 1 hour, or entire replacement of 1 unit of blood volume within 24 hours. And most of the time we aim at mean arterial pressure of 60 to 65 mm of Hg and hemoglobin of 7 to 9, and it should be less than 1.5. Platelets should be more than 50,000 and pH of 7.3 to 7.45, and fibrogen should be 1.5 to 2 gram per liter, and temperature should be maintained. And all the blood components should be transfused in a balanced manner. Like PRBC, FFP, and platelet should be transfused 1:1:1 ratio. And whenever fibrogen is less, we can add cryoprecipitates.
Okay, Dr. Lepakshi, can you tell us
Yes,
what are the 7 T's we should know in managing these cases?
Yes, the 70s, they serve as a helpful cognitive mnemonic framework to guide rapid systemic resuscitation and prevent complications like that lethal triad, which comprises hypothermia, acidosis, and coagulopathy. The trigger, the first T is the trigger. It defines exactly when to activate this protocol. We should avoid delayed activation. This triggers can rely on the clinical findings like the obvious hemorrhagic shock, the physiological parameters like shock index more than 1.0, the persistent hypotension and tachycardia. The second T, it is the team. Actually, the role allocation should be clear cut and with the leadership and communication structure. We have to designate the specific duties to the team, each member of the team, and enforce closed loop communication and who can share the situal awareness across the teams of clinicians, nurses, blood bank, and surgical or obstetric teams. Then the third T is the tranexamic acid. Here we start the early antifibrinolytic therapy. It is administered 1 to 2 grams IV as early as possible. It is ideally within 3 hours of hemorrhagic onset. It can reduce the bleeding related mortality. The fourth testing is the frequent laboratory and point of care evaluation. That is very important to drive goal directed therapy. Here, we send the baseline labs immediately and repeat hourly during active massive hemorrhage. And the essential parameters, which we have this hemoglobin, coagulation profile, the fibrinogen, calcium, and lactate, and of course the ABG. Then we have the fifth T, the transfusion. This transfusion it is a structured, balanced component therapy rather than blind fluid loading. We implement this fixed ratio component packs 1:1:1 or 2:1:1 ratios of PRBCs. We have the FFPs and the platelets. The temperature has to be this thing. We should prevent it, and management of hypothermia is very critical here. It actually the administration of fluids should be warmed up and then transfused. And hypothermia impairs coagulation enzyme function and severely worsens the lethal triad. So the last termination, we have to wind up the massive transfusion protocol. We should stop this protocol once surgical or the source control is achieved and bleeding has ceased and patient's hemodynamic stability is restored and the lab parameters are normalizing.
Very correct. Very correct. So all of us should remember the 7 T's, which is very important in managing the patient.
Now, after 4 hours later, the urine output is less than 100 ml, INR is 1.03, urea 64.2 milligram per DL, creatinine is raised to 3.3 milligram per DL. Dr. Savita, what will you do now?
Yeah, since the serum creatine is again double, it's double the normal range, which was earlier, it is increasing. She may go into the, may require dialysis, probably.
So can we still manage or you need help from someone?
We'll take advice from the nephrologist and take an opinion about this and go ahead with the.
May I intervene here?
Now the patient has been referred to tertiary care hospital. At the tertiary care hospital, she is afebrile, tachypneic, BP 160/98, pulse rate is 102, SpO2 90%, respiratory system bilateral clefts heart, tenderness para-abdomen at the suprapubic area. PV, she has a minimal bleeding with a urine output 400 ml since LSCS.
So, Pooja, at a tertiary
Yes,
hospital,
yes.
these were the investigations done.
Yes, yes. So there has been a lot of progress that has happened over the last few hours. And with the presence of a very reduced urine output and a desperate measure, probably this massive transfusion has been done, which could have been done under dialysis care because there is a high risk of hyperkalemia with massive transfusions. So ideally, in order to have a hemodynamic stability, probably massive transfusions have taken place. But in the real world scenario, there will be a simultaneous dialysis that will be going on in case the potassium is 7 and there is no urine output for this long with the requirement of massive blood transfusion. Yes, coming now that she has been referred to a tertiary hospital here, definitely there is a worsening of serum creatinine that's seen despite a timely delivery of the fetus with the presence of deranged LFTs, that is AST and ALT, presence of anemia and mild thrombocytopenia with an elevated LDH of 2000 plus. So here definitely there is an ongoing ATN. If the pathological diagnosis we have to think of, this probably is an ATN that has happened because of severe preeclampsia associated HELLP syndrome. So when the patient is having decreased urine output with presence of bilateral basal creps, it is definitely advisable to start on hemodialysis to stabilize the patient. The supporting
So
features here.
there was a thought whether it was HUS, whether it was TTP. So can you just throw light on this because we often get confused. We get confused HELP with HUS and TTP. So can you throw some light on how to differentiate these three things?
Yes, definitely, madam. So in the current case scenario, the way it has progressed and the rapidity of progression with the background of preeclampsia with abruption and bleed, still the diagnosis could be acute tubular necrosis. Most of the time, if there is acute tubular necrosis secondary to severe preeclampsia and HELP syndrome, there has to be an improvement in the next 48 hours. There is a very thin line of difference between the HELP syndrome and HUS. Usually what we take as a cutoff is first 48 to maximum of 72 hours. Post delivery, there should be a recovery of AKI, either partial or complete or whatever that is. If the creatinine persists to be higher, if there is no improvement in the urine output, or if there is worsening platelets, or if there is worsening LDH, we also send for a peripheral smear and look for schistocytes. Schistocytes are nothing but dysmorphic RBCs that are present whenever there is a HUS picture. So if there is a persistence of all these things despite day 3, day 4, then we have to entertain the diagnosis of atypical HUS, because both in HELP syndrome and HUS there is hemolysis, there is low platelets. Both will have elevated LDH. Both will have elevated serum creatinine. So the differentiating point for a HELP versus HUS is the improvement in serum creatinine after 3 days of delivery points more towards HELP, whereas persistent renal dysfunction or worsening renal dysfunction or persistent low platelets worsening hemolysis will favor a hemolytic uremic syndrome. So most of the time hemolytic uremic syndrome presents in the postpartum period, whereas HELP is more in the third trimester. TTP can be there in the second and third trimester, but HUS is more like in the postpartum period. And there are various differences that has been evidently described in this table. So what I would reinforce is a renal failure that is there in HELP, but in case of TTP the renal failure is mild, but in HUS the renal failure is very severe. TTP is always a pentad, where there is anemia, thrombocytopenia, fever with neurological symptoms. So here the neurological symptoms become more than the renal, whereas in HUS, the neurological symptoms won't be much, but it is a severe form of renal failure that will clinch the diagnosis. In hepatic dysfunction, definitely in HELP, but hepatic dysfunction will not be there in TTP and HUS. Decreased platelets are there in all throughout, but what we should know, in thrombotic thrombocytopenic purpura, the platelets will be severely low, say less than 20,000. Then our diagnosis goes in favor of TTP. LDH, definitely in HELP it will be elevated, but LDH will be very high in hemolytic uremic syndrome. So these are the subtle differences that we get to know whether it is HELP or a HUS. What we should understand, at least as a
looking at our patient, I think it fits into HELP more than TTP and HUS.
Yes, because we don't have a follow-up data here. After this, what happened and how it has gone. All of these systems include a complement activation. There is a complement pathway which gets triggered in HELP as well as in HUS. So these alternate complement pathways will be very silent until a first trigger develops, and the trigger is pregnancy. So that's how they manifest post pregnancy. So this is what I would like to stress upon.
So thank you very much. So this patient, in view of worsening renal functions, oliguria, fluid overload, she was initiated on hemodialysis. On alternate days, heparin-free hemodialysis was done. BP was controlled with 3 antihypertensives. Fortunately, liver functions, hemoglobin and platelet gradually improved, but she continued to be dialysis dependent with urine output of around 400 to 500 ml per day. At the end of 3 weeks, because of dialysis dependent state, a renal biopsy was done, which unfortunately showed cortical necrosis. And after 4 months, patient had life-related renal transplant. The donor was her own father, and at present, her renal function is normal. Serum creatinine is 0.9 milligram per deciliter. So here we have a patient who went on to have acute kidney injury, who went on to become dialysis dependent, and then she had a cortical necrosis, and fortunately, she matched with her father and had the renal transplant, and now she is doing well. We had another case, but for paucity of time, we will not do that. But however, I want all the panelists to just tell what are the lessons learned today in one sentence. Just in one sentence. Dr. Lepakshi, sir? Priyanka? Can you hear me?
Madam, preventing AKI centers on restoring and maintaining renal microvascular perfusion, correcting ischemia, and avoiding secondary renal insults, madam.
Yes. Priyanka? Jayashree?
Hello, ma'am. Definitely the early recognition of AKI is very important in reducing mortality and morbidity. And whenever is needed, we should activate massive transfusion protocol also, and we should take early nephrologist consultation to reduce the mortality.
Yeah, Jyoti?
Yes, ma'am. Whenever possible, we should always aim to prevent the permanent kidney injury and prevent the morbidity to the patient.
Kavita?
Yeah, ma'am. Since acute kidney injury, though rare, but it causes lot of more complications. So continuing the pregnancy with the acute kidney injury should be with a guarded prognosis, with frequent monitoring the risk factors and the renal function test, and timely deliver will help the pregnant woman from going into an cortical necrosis and renal hemodialysis dependent patients.
Priyamvada?
Ma'am, actually, the root cause of all this is the preeclampsia. First, we have to find out whether the patient is like she's going into she's like she's a candidate for hypertension disorder of pregnancy, and we have to treat her in the earlier stage itself.
Pooja, as a nephrologist, what do you expect from us?
Yes, so as a nephrologist, what I would expect is one, definitely there'll be a lot of patients who may still have PIH or mild preeclampsia. Post delivery, definitely the blood pressure will come down and they are lost to follow up. Now we have understood the pathophysiology of preeclampsia, that kidney is the root cause of patients who develop preeclampsia. Why do only few patients develop preeclampsia? There are a lot of theories about this, placental theory or the other angiogenic factors. But what I would like to stress is these patients are prone for further kidney injury, further CKD in the long run. So any patient who develops preeclampsia, mild or whatever, and then she is on follow-up with you all for first 1 month or 3 months maximum, then she is lost for follow-up. No blood pressure monitoring for the next 2-3 years. She comes back to us after 5 years with pedal edema, mild proteinuria, and the renal dysfunction. So this is the gap that is there between the obstetricians and the nephrologists. So the treatment or the continuation of care doesn't happen. So what I would recommend is every patient who is diagnosed with hypertension first time in pregnancy or a chronic hypertension superimposed on preeclampsia should have a further continuation of follow-up with the nephrologist to monitor proteinuria or the kidney function, so that we can delay the progression of the kidney problems. Second is any patient who I gave this example earlier, any patient who develops an acute coronary syndrome, he visits the cardiologist, he places a stent, and that patient regularly follows up with the cardiologist throughout his life. But any patient who develops acute kidney injury and recovers does not follow up further, because we as physicians lack the awareness that a small insult to the kidney, however well it has recovered, may not be a complete recovery. There will be partial recovery, there will be proteinuria persistent, they are prone to hypertension in future. So we should also remember that even if there is a complete recovery of AKI, they need further follow-up with the nephrologist.
Yeah.
Do
So
renal function test in the first trimester.
Is to diagnose it early, treat it promptly, and refer to the concerned person. But our responsibility doesn't end there. We have to insist on a follow-up both with us and with the nephrologist to see if her renal function is deteriorating. Thank you very much, all the panelists, for your contribution.
One more thing.
Remember, AKI is not common.
Hello.
Hello.
Rupa madam, one more thing I want to say. So as much as possible, avoid NSAIDs, especially in the postnatal period, especially patient who is pre-eclamptic. Another thing is always do not forget to do renal function test or especially serum creatinine in the first trimester of pregnancy.
Yes, so it is mandatory. So to conclude, AKI is not uncommon. AKI is preventable by good antenatal care, screening for underlying causes, diagnosis of the disease promptly, and timely management of underlying condition. However, even if it sets in, timely referral to a tertiary care center can prevent cortical necrosis and need for dialysis or transplant. So I hope we have passed on the message to whoever is present here, though a small number. I thank Dr. MC Patel for giving me this opportunity to moderate the session. And I thank all the panelists for their wonderful contribution. And let us all work together to keep our kidneys healthy and happy. Thank you very much.
Thank you, madam.
Thank you. Thank you, madam.
Thank you, madam.
Thank you, madam.
Thank you, ma'am.
for want of time, I'm not asking anyone to ask questions. But if there are any questions or any doubts, you can always message to my personal number.
Hello, good evening, ma'am. Rupa Prakash,
Yeah.
ma'am. Such a
Good
wonderful moderation you have done. I think a whole day is needed for any acute kidney injury class, but in 1 hour you have almost done such a wonderful work. I don't know. You are a genius in doing moderation of any panel, I feel. May I request Dr. Himamani, who is the nephrologist, senior nephrologist in Mysore and professor and HOD, to give her comments as an expert.
Good evening, madam.
Yeah.
I'm Rupa madam is my teacher. I have heard her talks always. Today also she has done a wonderful work along with her daughter. But in this scenario, whatever case discussion we had, TMA is always suspected, HUS is always suspected. Usually recovery occurs within 3 days in other condition, whether in other like HUS it does not recover. So I would suggest to keep a blood sample for genetic test and complement test in the refrigerator for at -20 degree. If required, you should also consider HUS as the differential diagnosis in such scenery, because nowadays there are treatment for HUS in a resourceful condition. There are drugs like eculizumab which can prevent or treat the condition like HUS. So I would, though all the things were optimal, a sample has to be kept for further analysis, genetic testing for complement mediated diseases also.
Yes, madam. Thank you. Thank you for that input, madam. Definitely it is worth this extension.
Thank you.
Thank you. Thank you for all the panelists. Such a wonderful thing they have done. And at the outset, I like to thank MC Patel sir for doing such a wonderful work. Entire Karnataka is here today. But I'm really, really sorry that postgraduates and so many people, they've missed such a wonderful session of today's CME. And I wish all the very best to Dr. MC Patel sir. And we hope to see him as president of Foxy upcoming. And thank you again.
Thank you
And
very much,
regarding the
sir.
subject, Madam has done everything, and all the panelists have done such a wonderful job, and even co-moderator Dr. Pushpalata. So there is not much to say from an OBG point of mind. Prevention is better than cure is my mantra. That's all. Thank you. Thank you, ma'am.
Thank you.
Thank you, everyone.
Sir, to you, thank you very much for the opportunity and all the best. I think like how we had a saying, each one teach one, we should all at least motivate one more person to vote so that the entire society votes. And we assure you that it will be total support from Mysore society. And I wish to see you adorning the chair of President of Foxy, sir.
Heartfelt thanks to both the moderators, Rupa ma'am, Gita ma'am. Thank you for the amazing panel. And thank you for the platform. Thank you, MC sir, requesting all of you to please support MC sir. Let him be the next president. And please encourage maximum people of your society to do the voting. Thank you all. We will see you all again.
Thank you. Bye, Suma.
Good night, madam.
Good night. Sonia, good night.
ಮೇಡಮ್ ಸಗದಾಗಾಯ್ತು, ತುಂಬಾ ಚೆನ್ನಾಗಾಯ್ತು, ವೆರಿ ನೈಸ್. ಪುಷ್ಪಲತಾ ಹೋಗಿ ನಿದ್ದೆ ಮಾಡಿ. ಚೆನ್ನಾಗಾಯ್ತು ಇಬ್ರದ್ದು, ಚೆನ್ನಾಗಿ. ಪುಷ್ಪಲತಾ ಮುಖ ತೋರ್ಸು ಒಂದ್ಸಲಿ ಈ ಕಡೆ. ಹಾ, ಎಸ್, ವೆರಿ ನೈಸ್, ಚೆನ್ನಾಗಾಯ್ತು ಮೇಡಮ್.
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಹೊಟ್ಟೋದ್ರು ಅನ್ಸುತ್ತಲ್ಲ.
ಹೌದೌದು, ಯಾರಿಲ್ಲ
ಬಟ್ ಮೇ ಬಿ ಹಿ ಇಸ್ ನಾಟ್ ಇನ್ ಫ್ರಂಟ್ ಆಫ್ ಸಿಸ್ಟಮ್. ಹಿ ಇಸ್ ದೇರ್ ಆಕ್ಚುಲಿ.
Anyhow, thank you. Good night.
Okay, see you
Thank
all on
you.
8th.
Madam, thank you very much, madam, for the opportunity.
Thank you, Lepakshi sir. Thank you so
Thank you,
much.
madam. Thank you so much.